All right, so a very good evening, everyone. Yes, so please just give me a quick thumbs up or please let me know. Am I audible to all of you? Yes, am I audible to everyone? All right, great. So now, so today's session first, I'll start with the cardiology, right? And yeah, right. So I have shared the PDF of the cardiology just now on my Telegram channel. So this is my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So it was not the yesterday's PDF which I have shared for you, right? I have just revised the PDF of the cardiology rapid revision. So I have sent to my Telegram channel. So please take the PDF or the PPT from my Telegram channel, right? So having said that, let us start with the yeah let us start with the discussion. Yeah, so this will be like for both the category of the students, those students who are appearing for the NEET PG and as well as the FMGE exam as well. And I will share you the PDF even after the session also, right? And what are all the topics that we will be discussing today is we will be discussing the cardiology, then we will be discussing connective tissue disorders, and then we will be discussing the nephrology, that is the kidney. So these are the topics that we will be discussing, right? Now, yeah, this session will be more than enough if you are thorough with your basics, right? Let us start with the first question. So we have a 60-year-old man comes to the emergency with history of chest pain, which is acute in onset. The ECG shows the ST segment depression and T wave inversion. The cardiac biomarkers are not elevated. What will be the appropriate management in this patient? Like we have the options like oxygen, aspirin, ticagrelor, metoprolol, oxygen sublingual nitrate, antiplatelet streptokinase, antiplatelet low molecular weight heparin subcutaneous, oxygen sublingual nitrates, and digoxin. Yes, right. So in this question, first of all, you need to know what exactly is the diagnosis. So now the first topic that I'll be discussing in the cardiology rapid revision is the ischemic heart diseases, that is coronary artery disease. So if you take the coronary artery disease, like how do we classify these coronary artery diseases is we classify these patients of coronary artery diseases into the one with ischemia, that is ischemic heart diseases, right? And the other one is the infarction, right? And this ischemia again, we have the stable angina, then we have the Prinzmetal angina, then we have the unstable angina. And the infarction based on the ECG, we classify this into like the NSTEMI and as well as the STEMI. Now, which category of this, to which particular category does this patient comes under? Any one of you? Right, very good. So Sajan has answered it correctly, right? Yeah, so it is the unstable angina. Now, why is it unstable angina? Why? Because the cardiac biomarkers are negative. The important difference between ischemia and infarction is that in case of ischemia, the cardiac biomarkers are negative, whereas in case of infarction, the cardiac biomarkers are positive. But the ECG is showing the ST segment depression and T wave inversion and the chest pain, it is acute in onset. All these are the points suggestive of the unstable angina. Now, in case of unstable angina, what is the correct answer here? The correct answer here is the oxygen, aspirin, ticagrelor, and metoprolol. What you have to understand and remember is that we have a clinical entity called acute coronary syndrome, right? In acute coronary syndrome, you need to give what are all the spectrum which comes under acute coronary syndrome. That includes the unstable angina, NSTEMI, and as well as STEMI. These are the three disorders which comes under your acute coronary syndrome. Now, in all these patients, you need to give the DAPT. DAPT stands for what? that is dual antiplatelet drug, right? What will be the dual antiplatelet drug? This dual antiplatelet drug, it includes the aspirin. Along with aspirin, you need to give the clopidogrel, right? You need to give clopidogrel, or you can also give ticagrelor. You can also give ticagrelor. Any of these antiplatelet can be given, but aspirin should definitely be given. And in all the patients with ischemic heart diseases, the beta blocker is very, very important. Beta blocker is very important. And all the patients with ischemic heart diseases, along with aspirin, you need to connect the patient to the oxygen. You need to connect the patient to the oxygen. Now, if we go back to our question, oxygen, aspirin, ticagrelor, and the beta blocker, that is metoprolol. Now, how is that the other options are incorrect? Please remember, this streptokinase, it is not given in unstable angina. Streptokinase is what it is, a thrombolytic therapy. This thrombolytic therapy, it is not given in case of unstable angina, and it is not given in case of the non-ST elevation MI. Thrombolytic therapy is indicated only in case of the ST elevation MI, right? Then why third answer is the incorrect answer? Why third one is incorrect? Actually, we do revascularization with heparin only, that is low molecular weight heparin. We do revascularization in case of the unstable angina. But the point that you need to understand here is very important part of the treatment in case of unstable angina is the oxygen therapy, right? Now, in this option, if oxygen therapy was also there, then the third answer would also be correct. Otherwise, the third option is also correct answer. But oxygen therapy should be there in the treatment of any form of ischemic heart diseases. Okay. And what about the fourth option? Right? Fourth option is that Digoxin, we don't give in case of ischemic heart diseases. Why? Because Digoxin, it will increase the cardiac contractility and it will increase the myocardial oxygen demand. And in patients with ischemic heart diseases, there is decreased blood supply to the myocardium. So when there is a decreased blood supply to the myocardium, right, when you give Digoxin, it will increase the demand. So the angina will get precipitated. So that is the reason why we don't give Digoxin in patients with the ischemic heart diseases, right? Now, and you need to understand that for this unstable angina and as well as NSTEMI, in both of them, the treatment is same, right? The treatment is same. What is the treatment is same? I will tell you. But you take in case of STEMI, in all the forms of acute coronary syndrome, the first line drug will be the aspirin, right? And in case of STEMI, the revascularization can be done by PCI, can be done by thrombolytic therapy, can be done by the CABG. But which is best method of revascularization? That is, the percutaneous coronary intervention is the best method of revascularization. Now, let me just quickly revise the unstable angina and as well as the NSTEMI, right? Now, you have to understand that the onset of angina in case of unstable angina and STEMI, it is at rest. It is acute in onset, right? It is acute in onset. Now, how is that it is different from stable angina? In stable angina, the chest pain will be there on exertion. Whereas in unstable angina and NSTEMI, the angina will develop at rest. It is acute in onset. Now, what will be the ECG finding in case of the unstable angina and NSTEMI is there will be STT depression. That is very important point. And what about the cardiac biomarkers? The cardiac biomarkers in unstable angina, it is negative. Whereas cardiac biomarkers in case of NSTEMI, that will be positive. And what did I tell you? In any form of the acute coronary syndrome, right, the aspirin is the first line treatment. And you need to give a loading dose. And what is a loading dose? 325 milligrams of aspirin should be given as the loading dose. And along with that, oxygen and the anti-anginal drugs should be given. Now, what is that anti-anginal drugs? These anti-anginal drugs that will be given are either nitrates, and in emergency department, you can also give the morphine. Right? In emergency department, you can also give morphine. And the anticoagulants that we give, please remember, we don't do thrombolysis. The anticoagulant that can be given in case of the unstable angina or NSTEMI is, you can give unfractionated heparin, you can give low molecular weight heparin, right? Or you can also give the fondaparinux. This is also fondaparinux, right? So this is also the anticoagulant. And I said you no thrombolytics in unstable angina or NSTEMI. And in any form of acute coronary syndrome, the best method of revascularization is the percutaneous coronary intervention. Okay. So this is about the unstable angina and as well as the NSTEMI, right? Now, I'll show you one more question, which is very, very important. You see this question, right? I'm repeating this point again. The revised PPT of the today's cardiology session, I have sent that on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So please don't follow the yesterday's cardiology PPT, which I have sent as the final revision. I have sent the revised PDF, okay? Right. Now, you see this question. What is the significance of the ECG segment that is depressed during a chest pain episode in a patient with unstable angina? What is the significance of the ECG segment that is depressed during the chest pain episode in a patient with unstable angina? Right, great. So, yes. So, in case of unstable angina, what is being depressed? It is the ST segment which is being depressed. What is the ST segment? ST segment is the segment which represents the period between the ventricular depolarization and as well as the ventricular repolarization. Okay. What is the segment that indicates atrial depolarization? That is the P wave. What is the segment that represents ventricular depolarization? That is the QRS complex. What is the segment that corresponds to ventricular repolarization? That is T wave. So what is being affected in unstable angina is ST segment, which is the segment between the ventricular depolarization and as well as the ventricular repolarization, right? Next question. Yes. Which of the following is now, this question is on, right? This question is on the risk factors which are associated with the development of ischemic heart diseases. That is atherosclerosis. That means what are the risk factors for atherosclerosis? Right? Based on this, the question is being framed. Which of the following is least likely to predispose to the underlying pathology responsible for a 55-year-old male symptoms of exertional squeezing chest pain and shortness of breath? Yes. The question is like least likely to predispose. Any one of you, please? Great. So the correct answer is from, right. The correct answer is from Pratyusha, right? So the answer here is D. The answer here is D. Now, what is the correct answer? I mean, why it is least likely? Let me tell you. Remember, it is not high lipoprotein B to apolipoprotein A ratio that will be predisposing to the development of the ischemic heart diseases, right? Now, it is exactly reverse. It is exactly reverse. That is high lipoprotein A to that of apolipoprotein B. This particular ratio is the one which has significance in the development of atherosclerosis. This is the risk factor. It is not B to A ratio. It is A to B ratio, right? And the others, right? Increased LDL. Please remember, this is very, very important. Increased LDL, it is associated with the progression of atherosclerosis. And decreased HDL, there is impairment of reverse cholesterol transport. That is the problem in case of this. Next is hyperhomocystinemia. So whenever there is increase in the homocysteine levels, this increased homocysteine, it is associated with endothelial dysfunction. And this endothelial dysfunction is the one which can progress the development of the atherosclerosis. And this hyperhomocystinemia, it is also associated with the inflammation, right? So endothelial dysfunction and inflammation, both of them, they are the predisposing factors for the development of atherosclerosis. And even your high sensitivity CRP, this is also the marker of the systemic inflammation, which can predispose to the development of the atherosclerosis. right? What is the question asked here? The question asked is least likely to predispose, right? Now, so this is the learning point. I have given you this in the PDF. So high sensitivity C-reactive protein, elevated total cholesterol, lipoprotein A to lipoprotein B ratio, then hyperhomocystinemia, high LDL and low HDL. So all these are the risk factors for the development of the atherosclerosis, right? Now, we'll move on to the next question. This is a very important clinical scenario. So we have a 60-year-old man with a 25-year history of smoking. Presents to a clinic due to recurrent chest pain whenever he walks fast. It is a squeezing sensation in the center of his chest and radiates to his left arm. His blood pressure is 160 by 100. Heart rate is 110 beats per minute. The ECG shows sloping ST segment depression in 2-3 AVF, that is inferior leads. What is the diagnostic test of choice? Coronary angiography, stress echocardiography, treadmill test, myocardial perfusion imaging. No, it is not STEMI. Pratyusha, this is not STEMI, right? This is not STEMI. Okay, there is ST segment depression in 2-3 AVF. Right? And when is that the patient is having chest pain? The patient is having chest pain, recurrent chest pain, whenever he walks fast. What is the clinical diagnosis? Anyone? What is the clinical diagnosis of this patient? No. This is not unstable angina. This is not NSTEMI. This is not inferior wall MI. Right. Very good, Bhuvana Raghu. So this is a case of stable angina. No, this is a case of stable angina because the chest pain is there on exertion in these patients. Right. Now, in case of stable angina, if the ECG is showing the ST segment depression, what will be the next important investigation that we need to do? In case of the stable angina, the next important investigation will be the stress test. Right? Stress test. What will be that stress test? That is treadmill test or dobutamine stress echo. Right? So the answer is TMT. Actually, coronary angiography, that will give you very clear picture of the coronary artery. Coronary angiography will give you completely clear picture of the coronary artery. But the point is, this coronary angiography is reserved. The coronary angiography, it is reserved where the patient's symptoms and non-invasive test results are inconclusive. When non-invasive test results are inconclusive, then we do the coronary angiography. Otherwise, the best investigation here is the treadmill test in case of the stable angina. Why am I calling this word as stable angina? Why? Because the patient is having chest pain upon exertion, that is walking, right? So the investigations that you will be doing in chronic stable angina is ECG, then the exercise stress test, which is nothing but the treadmill test. And on the treadmill test, the protocol that we follow is the Bruce protocol for diagnosing the TMT. And when the individual is not able to run over the treadmill, then we use what is called dobutamine stress echo for doing the stress test. And Duke scoring is the one which will help us to assess the severity of the chronic stable angina, right? And we have another option, that is myocardial perfusion imaging. What is the importance of this myocardial perfusion imaging? Please remember, the importance of myocardial perfusion imaging is to assess the myocardial activity. Then the other investigations are PET scan. PET scan is used to differentiate the scar tissue from the hibernating myocardium. Can anyone tell me what is hibernating myocardium? We have two terminologies. One is hibernating myocardium, right? And another important is the stunned myocardium. Yes, any one of you? What is the difference between the hibernating myocardium and as well as the stunned myocardium? Yes, difference between hibernating and stunned myocardium. Please remember, both of them, they are reversible conditions, right? Hibernating and as well as stunned myocardium, both of them, they are the reversible conditions. Hibernating myocardium is the one which occurs due to chronic ischemia, right? It occurs due to the chronic ischemia, whereas the stunned myocardium, it is due to acute ischemia. And whenever the blood flow is like regained, then the myocardial contractility will improve. Okay, so PET scan. What is scar tissue? Scar tissue is a completely dead tissue. So PET scan is the one which helps us to differentiate the scar tissue from the hibernating myocardium, right? Yeah, very good. Now, let me take up the discussion related to the chronic stable angina. So chronic stable angina is that where these patients, they will have reversible ischemia and the chest pain will be there only on exertion. The chest pain will be there only on the exertion. And what will be the duration of the chest pain in chronic stable angina is less than 10 to 15 minutes. And what is Levine sign? Levine sign is that the patient will clutch the fist over the precordium while explaining or while describing the chest pain. He will place the fist over the precordium while describing the chest pain. That is what is called Levine sign. So what does the ECG show in case of the stable angina? The ST segment depression, right? And the TMT and the dobutamine stress echo, this is the one which can, these are the non-invasive tests which will confirm the stable angina, right? The treadmill test and hibernating and stunned myocardium. So hibernating myocardium, it is the myocardium is not able to contract because of chronic ischemia, whereas stunned myocardium, it is an acute event. Now, what is the first line drug or drug of choice? Drug of choice in patients with the chronic stable angina is the beta blocker. The beta blocker that we will have to take is the cardioselective beta blocker. Example, metoprolol should be given. Right? And another important is the anti-anginal drug. That anti-anginal drugs include nitrates. The other one is ranolazine. But this ranolazine, it is given in cases of the chronic angina. And please remember, in case of stable angina, we don't give dual antiplatelet therapy. In stable angina, like what we give is the single antiplatelet, that is either aspirin or clopidogrel is being given. Right? Either aspirin or clopidogrel is being given. So this is about in quick revision related to the chronic stable angina or reversible ischemia. Right? Now, you see another question. Which of the following tests is used to detect reversible myocardial ischemia? What are the tests which are useful for assessment of the reversible myocardial ischemia? What is this reversible myocardial ischemia? That is what I was discussing, right? That is hibernating myocardium, right? Or the stunned myocardium. Right. Very good. So it is not Muga scan. It is the thallium scan. It is a thallium scan which we use for detecting the reversible myocardial ischemia. So where do we use thallium scan? That is in SPECT. That is in SPECT. We actually have one more imaging, that is PET, that is positron emission tomography. Both of these, this PET and as well as SPECT, both of them, they are useful for detecting the reversible myocardial ischemia. And what are the radioactive tracers that we inspect? We use thallium scan. But what is the radioactive tracer that we use in PET? In PET, the radioactive tracer that we use is N13 ammonia, then rubidium-82. And then rubidium-82. But again, if the question, see, if both the options are there, if PET is also there in the option and SPECT is also there in the option, then what will be the correct answer? If PET and SPECT, both of them are there in the options to detect the reversible myocardial ischemia, what will be the best answer for you? Yes? Very good, Shravanti Kodali. So the best one is the PET scan. Not SPECT, it is PET scan. Okay, I'll show you this table I have given for you in the PDF which has been sent on my Telegram channel. So if you observe here, the sensitivity, you see this point. Okay, so if you see the point there, the higher sensitivity is there for PET scan rather than SPECT for diagnosing reversible myocardial ischemia, right? So that was the story related to PET scan. Now, what is the drug of choice in stable angina? We have discussed, like you see this question, that is beta blocker. You see this question. We have a 55-year-old male visits to the clinic for follow-up after receiving a diagnosis of chronic stable angina. In his previous visit, he was prescribed aspirin, metoprolol, isosorbide mononitrate, atorvastatin. Which of the following is a non-cardiac use of the class of drug that metoprolol belongs to? Yes. Anyone? So, yeah, metoprolol is what? It's a beta blocker, right? So this particular beta blockers, just give me 1 minute. 1 minute. Right. So this beta blockers, your metoprolol is what? It's a beta blocker. And this particular beta blocker, remember, it has many non-cardiac uses. This is a very, very important question. The non-cardiac uses of beta blockers. The non-cardiac uses of beta blockers are like glaucoma, right? We use timolol. Then restlessness, that is akathisia, we use beta blocker. Essential tremors, we use beta blocker. Performance anxiety and prophylaxis of portal hypertension, pheochromocytoma, we use beta blocker. Infantile hemangioma, we use beta blocker. Thyrotoxicosis, we use beta blockers. And prophylaxis of migraine, we use beta blocker. So these are all the, right, these are all the non-cardiac uses of the beta blockers. This is a very, 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 very important question, right? Then, now, after having discussed about the beta blockers, you see another question. What is the most likely diagnosis for a patient with recurrent central squeezing chest pain, deeply inverted T waves in V2 and V3 on the ECG? Yes, can anyone answer this question? Very, very important. Stable angina, unstable angina, pulmonary embolism, and Wellens syndrome. Yes. Right. So we have the correct answer from Sajan and as well as Buhana Raghu. Right. So this is not pulmonary embolism, right? What exactly is this? This is the Wellens syndrome. This is Wellens syndrome. Now, what exactly is the Wellens syndrome? Let me tell you, and how to diagnose this Wellens syndrome, I'll tell you. Okay. Now, if you take this Wellens syndrome, the Wellens syndrome, this represents the, what is another name for Wellens syndrome, first of all? The another name for Wellens syndrome, it is also called as the LAD, that is left anterior descending artery coronary T wave syndrome. That is what is called as the Wellens syndrome. Now, the clinical importance of this Wellens syndrome is it is the pre-infarction stage. It is a pre-infarction stage. Okay. And this Wellens syndrome, it is of two types. How to diagnose Wellens syndrome, I'll tell you. Right? That is Wellens syndrome type 1 and type 2. But between these two, which is more common? Wellens syndrome type 2 is more common. What will be the clinical feature? Basically, it is an ischemic heart disease. The individual will have chest pain. Which vessel is affected in case of the Wellens syndrome? It is the proximal left anterior descending artery. This will undergo critical stenosis. Right? This will undergo critical stenosis. That means if you leave it like that, the patient will have the infarction. What type of infarction? The anterior wall MI will be observed. Then what does the ECG show? ECG will show you a deep T wave inversion. And what is the difference between type 1 and type 2 Wellens? Okay, so is that ECG? Okay, fine. So what is the difference between type 1 and type 2 Wellens? In case of type 1 Wellens, you have deep T wave inversion, right? Whereas in case of type 2 Wellens, you have biphasic T wave inversion. right? You have biphasic T wave inversion in case of type 2 valence. That is what is the difference between, and in which leads you will have this in leads V2 and V3, right? In leads V2 and V3, you have these ECG changes. Then what is the immediate next step that you need to do? You need to do a coronary angiogram. What is the intervention that you need to do? The PCI, percutaneous coronary intervention. Okay, so that is what is your Wellen syndrome. Wellen syndrome, it's a pre-infarction stage of the myocardial infarction, right? So that was a story related to the Wellens, right? Then, now after having discussed about the Wellens, yes, this is also a very, very important question. Let me see how many of you can answer this. We have a 55-year-old female presents with recurrent early morning chest pain, which tends to reduce and disappear as they progress. She has a medical history of Raynaud's phenomena, and ECG showed ST segment elevation, while cardiac biomarkers and serial troponin values are normal. Which of the following amino acid is responsible for this condition? Methionine, lysine, arginine, aspartic acid. Now, can anyone tell me what is a clinical diagnosis? Yes. Can anyone tell me what is a clinical diagnosis of this clinical scenario? Anyone? Right. So, great, great. So we have the correct answers from some of the students. Yes, that is the arginine. Yes, very good, Bhuvana Raghu. So the clinical diagnosis here is, it is vasospastic angina, right? Vasospastic angina, or this is also nothing but the variant angina. Variant angina, which is nothing but the Prinzmetal angina. Which is nothing but the Prinzmetal angina. Now, so which particular amino acid is being defective here? That is arginine. Now, why? Why arginine is coming into the picture here? Remember, in patients with vasospastic angina, what they will have is, they will have transient coronary vasospasm. Right? There will be transient coronary vasospasm. Why there is vasospasm? I'll tell you. We have a substance called nitric oxide. This particular nitric oxide, this is what is responsible for vasodilatation of the coronary artery. Now, where is this nitric oxide being synthesized from? This particular nitric oxide within the endothelium, it is synthesized from the amino acid that is arginine. Arginine, in the presence of enzyme nitric oxide synthase type 3, this gets converted into nitric oxide. And this nitric oxide is the one which will cause coronary artery vasodilatation. Now, what happens in these patients with the variant angina is the arginine levels will get reduced. So once the arginine levels are being reduced, what will happen to the nitric oxide levels? The nitric oxide levels will be reduced, and thereby there will be transient coronary vasospasm. Okay, so the Prinzmetal angina, which is also called variant angina, right? Let me just quickly recap. So what should be the severity of the spasm? More than 90% of the vessel, it gets occluded. More than 90% of the vessel, it gets occluded. But it will be transient coronary vasospasm. And whenever there is vasospasm, these patients, they will complain of the chest pain. And this chest pain will be there only during, so it's a brief. Okay, it will be there for a few minutes whenever there is the vasospasm. And which vessel undergoes vasospasm most commonly? Right, most commonly it is the right coronary artery which will undergo vasospasm commonly. And during which part of the day the vasospasm is more common? That is, the chest pain is more common during early morning, right? And what will be the ECG finding? ST segment elevation, whichever vessel undergo coronary vasospasm. Yeah, so the only type of angina, right? The only angina where you will have ST segment elevation is the Prinzmetal angina. And what exactly is the pathophysiology? The pathophysiology is decrease in the arginine amino acid levels, and thereby there will be decrease in the nitric oxide levels. The ECG will show you that there is ST segment elevation. And cardiac biomarkers, because this is an angina, the cardiac biomarkers are negative. And if you take the treatment in these patients, drug of choice is nitrates. Then what are the alternative drugs? The alternative drugs that we give in these patients is the calcium channel blockers. Now, the quick question is the aspirin. Can we give aspirin in these patients? Can we give aspirin in these patients with the Prinzmetal angina? So please remember, the aspirin, it is usually avoided. Aspirin should not be given in these individuals. Okay, very, very important point. And what is the usual age of presentation is 30 to 60 years. And what are the risk factors for the development of the vasospastic angina is very, very important is smoking, right? The next important is the exposure to the cold. Then vasospastic disorders, that is Raynaud's phenomena. Okay, so this is about your Prinzmetal angina, which is also called as the vasospastic angina or variant angina, right? So that is about the story related to the coronary artery diseases or ischemic heart diseases. Then, yes, you answer this question. Which of the following is not the differential diagnosis of the ST segment elevation in the ECG? Acute pericarditis, trauma to the ventricles, hypothermia, hypocalcemia. Yes, not a differential diagnosis for the ST segment elevation. No, I did not get the correct answer from any one of you. Right, so very good. SS has answered it correctly. That is hypocalcemia. Hypocalcemia, you will not have the ST segment elevation. Whereas in acute pericarditis, trauma to the ventricles and hypothermia, in all these conditions, you will have the ST segment elevation. Now, so if you take the differential diagnosis for ST segment elevation, right, this is a mnemonic, right? So this has been provided to you in the PDF, which I have sent on my Telegram channel. The mnemonic is the elevation, right? The mnemonic is elevation AB. E stands for electrolyte abnormalities like hyperkalemia. L is your left bundle branch block. E stands for early repolarization variant. VA stands for ventricular aneurysm. T stands for trauma to the ventricles, right? Trauma to the ventricles during pericardiocentesis that will cause ST segment elevation, right? Then ischemic injury like myocardial infarction. Then hypothermia, where you have the presence of Osborne wave, non-occlusive vasospasm, that is Prinzmetal angina, then acute pericarditis, then followed by the Brugada syndrome. So these are all the conditions where you will have the ST segment elevation. But remember, in hypocalcemia, what will be the abnormal ECG finding is you will have long QT interval. Right, you will have long QT interval in case of the hypocalcemia. That is the abnormal ECG finding in hypocalcemia, right? Now, let me just quickly show you all the ECGs where you have ST segment elevation. So this is the ECG of the hyperkalemia, right? So how is that you are able to identify? You are having the tall T wave here, okay? Followed by that, you are having wide QRS complex in these patients, right? And followed by that, there is also the ST segment elevation, okay? And that too tall tented T wave, right? Suggestive of the hyperkalemia, right? Then the another condition where you have ST segment elevation is left bundle branch block. So this is the ECG of left bundle branch block. What will be the ECG changes in LBBB? You will have wide QRS complex, right? And you have, right, W-shaped S wave in V1, and you have M-shaped R wave in V6. Okay, so this is suggestive of the LBBB. What are the causes for LBBB? Anterior wall MI. This is one of the important causes for LBBB. Aortic stenosis can also cause the left bundle branch block, right? So that was about the story of LBBB ECG, right? Now, what is this particular ECG suggestive of? This is benign early repolarization. In benign early repolarization, you will have ST segment elevation in V2, V3, and then V4. Okay, V2, V3, and then V4. Now the question comes, sir, how will you differentiate benign early repolarization from anterior wall MI? In anterior wall MI, you will have ST segment elevation from V1 to V4, right? Even it can be V2, V3, V4 also. But in anterior wall MI, you will also have reciprocal changes, right? What are these reciprocal changes? Reciprocal changes are those where you have ST segment depression in 2-3 AVF. Right, in 2-3 AVF, you are having ST segment depression, right? And in benign early repolarization, there is no reciprocal changes. There is no reciprocal changes. Okay, so this is about another condition where you will have the ST segment elevation. Right now, the another condition is tomb-shaped ST segment elevation. Tomb-shaped ST segment elevation that is observed in case of the ventricular aneurysm. You can see that. This is your tomb-shaped ST segment elevation observed in the ventricular aneurysm. Now, what is the cause of ventricular aneurysm? The cause of ventricular aneurysm will be the anterior wall MI can cause the ventricular aneurysm. Okay, then. Now, the another condition where you have ST segment elevation is anterior wall MI. Just now I was discussing, in anterior wall MI, what should be there? There should be ST segment elevation from V1 to V4. What did I tell you? Reciprocal changes, where in 2-3 AVF. It can be in any of these inferior leads. So you can see that here. You have ST segment depression in lead 3. That is enough, right? But in benign early repolarization, you don't have this ST segment depression. Reciprocal changes will not be there, right? And this patient is also having lateral wall MI because the ST segment elevation is there even in one AVL, V5, and to a certain extent V6 also. So this is the ECG of the anterior wall MI. And another important differential diagnosis where you will have the ST segment elevation is in case of pericarditis. So in pericarditis, the ST segment elevation is observed, and that too, it is a concave ST segment elevation that is observed in all the leads, right? That is observed in all the leads, except you will have ST segment depression in AVR. And along with these findings in acute pericarditis, you will also notice that there is PR segment depression in all the leads, right? PR segment depression in all the leads, except in AVR, you have the PR segment elevation. So this is the ECG of your acute pericarditis. Then in the pneumonic, like you have AB, that is Brugada syndrome. Yeah, right. We'll take one quick question from Nazi Abdul Samad. So he's asking, sir, why to avoid aspirin in case of the Prinzmetal angina? So please remember, aspirin is what? It is an NSAID, non-steroidal anti-inflammatory drug, and it is a COX inhibitor. Okay, and you know, this particular aspirin, it is not only having the antiplatelet effect, it can also cause vasospasm. It can also cause vasospasm if there is pre-existing vasospastic nature. If there is pre-existing vasospastic nature, aspirin can precipitate the vasospasm. That is the reason why the aspirin is avoided in patients with the Prinzmetal angina. Okay? Right. Now, what is this? Here you are having the ST segment elevation in lead V1 and as well as V2. And that too, what is the character of the ST segment elevation? It is saddle-shaped ST segment elevation. The saddle-shaped ST segment elevation that is suggestive of the Brugada syndrome. So Brugada syndrome, it is a disorder where you have abnormality in the sodium channel, that is SCN5A. And in case of Brugada syndrome, these patients, they are at increased risk of the arrhythmias, that is VT and as well as the VF, right? And yeah, you can describe it anyway. So either saddle-shaped ST segment elevation. Then what is the treatment of choice in these individuals? You need to give or you need to place the ICD, that is implantable cardioverter defibrillator should be placed. Implantable cardioverter defibrillator has to be placed. So that was about the story related to the ST segment elevation. Now, yes, this is another very important question. Which one of the following is a non-shockable rhythm in respect to use of the automatic external defibrillator? Non-shockable rhythm. Great. So, pulseless electrical activity. Pulseless electrical activity, it is a non-shockable rhythm, right? Now, let me quickly recap what all the shockable rhythms and what are all the Non-shockable rhythms I will discuss. So if you take shockable rhythms, shock, and when will you give shock is, that is DC shock, whenever the patient is hemodynamically unstable. Patient is hemodynamically unstable, then we give this particular shocks. Like that is in case of hemodynamically unstable VT and ventricular fibrillation, this is always unstable. Ventricular fibrillation, this is always hemodynamically unstable. Then atrial fibrillation, then even in atrial flutter, right? And even in case of the supraventricular tachycardia. But the background should be hemodynamically unstable. Hemodynamically unstable means what? Where the systolic blood pressure is less than 90/60. Respiratory rate, there is tachypnea. Respiratory rate, there is tachypnea. So where the respiratory rate is more than 30 per minute. And the saturation, it should be desaturation. Where the SpO2, it should be less than 90%. And the patient should be in a state of the pulmonary edema. Right? And there should be bilateral crepitations. Okay. So, yes. So these are the scenarios where you give shock. Now, the question comes, which are non-shockable rhythms? The non-shockable rhythms is, right? The non-shockable rhythms are the asystole. Non-shockable rhythms are asystole and then PEA. What does this PEA stands for? Pulseless electrical activity. Pulseless electrical activity. That is what is called PEA. Right? That is pulseless electrical activity. Now, again, when you are giving DC shock, we have two forms of DC shock, synchronous and as well as asynchronous DC shock. Where will you give synchronous DC shock? Synchronous DC shock, you give in case of VT, ventricular tachycardia, we give the synchronous DC shock, right? And even in case of the SVT, synchronous DC shock, that means where we synchronize the shock with the QRS complex. That is what you mean by the word synchronous DC shock. Then in case of the atrial fibrillation, then where is that you will have supplementation of asynchronous DC shock. Asynchronous DC shock we give in case of VF, right? And as well as pulseless VT. Right, pulseless VT. Okay, so we give asynchronous DC shock. So that was about the story related to the shock. And whenever in these two scenarios, whenever you are giving the DC shock, what should be the strength of the shock? The strength of the shock, it should be around 200 to 360 joules. And what is the strength of the shock in atrial fibrillation? That is around 200 joules. And what is the strength of the shock in atrial flutter? That is around 50 joules. That is around 50 joules. Okay. So this is about the story related to the DC shock. Done. Now we'll move on to the next question. A 50-year-old man reports to the emergency with breathlessness, palpitations, and acute chest pain. On auscultation, there is systolic murmur at the apex, and ECG shows the ST segment elevation in the anterior chest leads. Which of the following would be the next choice of the investigation? So cardiac marker, that is troponin INT, echocardiography, TMT, and 24-hour Holter monitoring. Now, can anyone tell me the diagnosis? Can anyone tell me what is the diagnosis? No. See, like the patient is having the ST segment elevation in the anterior leads. That itself is telling you that the patient is having the anterior wall MI. That itself is telling you the patient is having anterior wall MI, right? Then what is the purpose of doing, again, the cardiac troponins? What is the purpose of doing cardiac troponins? It is no use. But now my question is, why there is systolic murmur at the apex? My question is, why there is systolic murmur at the apex? Any one of you? Very good SS. So the presence of the systolic murmur, it tells you that the patient has developed mitral regurgitation. Then how is that you will diagnose this mitral regurgitation? That is by echocardiography. So the correct answer here is the echocardiography, not the cardiac troponins, right? So this is one of the complication in case of MI. So if you take the complications of MI, we classify the complications of the MI into the following. One is the structural complications of the MI, then electrical complications of the MI, right? Electrical complications of the MI, then long-term complications in patients with the MI. You take structural complications. Structural complications include MR, that is observed in anterior wall MI, and as well as the inferior wall MI. Then VSD, that is observed in the anterior wall MI, right? Then cardiac rupture. These are the structural complications. Now, why in case of anterior wall MI and inferior wall MI, you have MR? Because you take the papillary muscles. Papillary muscles, which are connected to caudate tendinae and as well as mitral valve, they are present on the anterior wall and inferior wall. So whenever there is anterior and inferior wall MI, papillary muscle will get ruptured and these patients can develop acute MR. Okay, because the support to the caudate tendinae are lost and there will be mitral valve prolapse. Now, why in case of anterior wall MI, you have ventricular septal defect? Because in anterior wall MI, the left anterior descending artery is blocked. Left anterior descending artery, it supplies anterior 2/3 of the interventricular septum. When left anterior descending artery is blocked, the blood supply to the anterior 2/3 of the interventricular septum is gone. That will result in the ventricular septal defect. Electrical complications can be either tachyarrhythmias, that is your VT or VF, and then bradyarrhythmias, and these bradyarrhythmias include even complete heart block. This complete heart block, it is commonly observed in the inferior wall MI or right ventricular MI. Why? Because in inferior wall MI and right ventricular MI, the vessel that is blocked is right coronary artery. Right coronary artery is having a branch that is AV nodal branch. So if right coronary artery is blocked, the AV nodal branch is also gone. That will result in the complete heart block. And the long-term complications that you will observe in these patients will be the development of the Dressler syndrome. Okay, so what is Dressler syndrome? Dressler syndrome is post-myocardial infarction pericarditis. That is what is called as the Dressler syndrome, right? It's a long-term complication. This will occur after a few weeks to months after the development of MI. And it's an inflammatory disorder. So ESR is elevated. And what is the treatment that you'll be giving in case of Dressler syndrome is you need to give high-dose aspirin should be given in these individuals. If the patient is not responding to high-dose aspirin, then you can give colchicine. And if the patient is not responding to colchicine also, then we give steroids, which are also the anti-inflammatory drugs. Okay, so this is about the complications related to the myocardial infarction. Okay, then. Right. Now, we'll move on to the discussion on some of the ECGs. We'll do a quick discussion related to the ECGs. So we are done with the coronary artery diseases. We are done with the complications related to coronary artery disease and multiple other questions also we have discussed. Which of the following ECG findings are the manifestation of the digoxin intoxication? ECG manifestation of digoxin intoxication. Right. So the correct answer, what we got, yes. So the answer is 2 here. So there will be development of ventricular bigeminy, ventricular tachycardia, and atrial tachycardia with variable AV block, but atrial flutter is not observed. So what you have to remember is, in case of the digoxin-induced arrhythmias, in digoxin-induced arrhythmias, you will have the tachyarrhythmias and you will have the bradyarrhythmias also, right? All the tachy, all the brady. But please tell me, which are the arrhythmias not observed in digoxin toxicity? Yes, please answer this question. What are the arrhythmias not seen in digoxin toxicity? Quickly. The arrhythmias not seen in case of the digoxin toxicity includes the atrial fibrillation, does not include the atrial flutter, right? And as well as Mobitz type 2 AV block. Mobitz type 2 second degree AV block. So except for these, all the types of tachy and bradyarrhythmias can be observed in case of the digoxin toxicity, right? And in case of digoxin toxicity, what is the important clinical manifestation? The earliest clinical manifestation will be in the form of the nausea or the vomiting, right? Nausea or vomiting. And if you take the vision of these individuals, there will be yellow vision. And these patients, they develop what is called gynecomastia. There are many other drugs, okay, which will be causing gynecomastia. And I hope everyone is aware of this particular mnemonic called DISCO. That is digoxin, isoniazid, spironolactone, cimetidine, and as well as the estrogen supplementation, right? And there will be also development of the delirium. Then, how is that you will treat the patients with the digoxin toxicity? First and foremost, very important part of the treatment is withhold the drug. Okay, stop the drug supplementation, and you need to monitor the potassium. And if there is hypokalemia, you need to give KCL, because hypokalemia will precipitate the digoxin toxicity. And what is the drug of choice for digoxin-induced VT? Anyone? What is the drug of choice for digoxin-induced VT? Yes? Drug of choice in the digoxin-induced VT. Excellent. So, the drug of choice in case of digoxin-induced VT, that is lignocaine, right? Or the lidocaine, okay? And what is the antidote here? That is digibind, which is nothing but the digitalis antibody, right? So this is the management of the digitalis overdose, right? Now, coming on to the next question. We have a 42-year-old male presents to the cardiology clinic with complaints of intermittent palpitations and lightheadedness. His ECG reveals a pattern consistent of Langerhans-Levin syndrome. Which of the following ECG findings are not characteristic features of this particular condition? The PR interval is short, QRS complex is normal, PJ interval is short, PJ interval is long. No, it is not amiodarone, which is a drug of choice for digoxin-induced VT. For digoxin-induced VT, drug of choice is lidocaine, okay? Right. So the correct answer is coming from Sunil Acharya and as well as the Anisul Nabi. That is, the PJ interval being long, it's a wrong statement in case of Langerhans-Levin syndrome. What exactly is Langerhans-Levin syndrome? It's a pre-excitation syndrome. Okay. Now, we have two important examples of the pre-excitation syndromes, right? Now, what are the two important examples of pre-excitation syndrome is Wolff-Parkinson-White syndrome and as well as Langerhans-Levin syndrome. What is the difference between these two? The accessory pathway in case of Wolff-Parkinson's is bundle of Kent and bundle of James is in Langerhans-Levin syndrome. The important difference is the QRS complex. It will be wide in WPW syndrome, narrow in Langerhans-Levin syndrome. And in WPW syndrome, you will have the presence of delta wave, right? Whereas in Langerhans-Levin syndrome, you don't have the delta wave. And PJ interval, it is variable in WPW syndrome. It is short in case of Langerhans-Levin syndrome. Now, what is this? This is the ECG of the WPW syndrome, where you are having short PR interval, okay? And this is the delta wave, and you are having wide QRS complex. You are having the wide QRS complex, okay? Whereas Langerhans-Levin syndrome, if you observe, this is the ECG of Langerhans-Levin syndrome, right? I'll just zoom this. So the PR interval, it will be short. The QRS complex, it is narrow, right? Then you take the PJ interval will be reduced. PJ interval will be reduced. What is PJ interval actually? What is J point? This is what is your J point actually. This is the J point. Now, because the PR interval is reduced, automatically the PJ interval also will get reduced. Okay. So J point is nothing but the end of the S wave is nothing but your J point. Right. So this is about the differences between, and you also need to know why the QRS complex is normal in case of the Langerhans-Levin syndrome. In Langerhans-Levin syndrome, you have the accessory pathway, that is bundle of James. The accessory pathway, it is bypassing the AV node. From the SA node, it is directly over the bundle of S. And the ventricular contraction is through the normal conduction pathway. So that is the reason why the QRS complex is narrow, but the PR interval will be shortened. But in case of the WPW syndrome, in Wolff-Parkinson's-White syndrome, you have the accessory pathway which is connecting to the ventricle. So the ventricular activation is not through the conduction pathway, it is through accessory pathway. Thereby, the individual will have wide QRS complexes, right? So that is the differences between your WPW syndrome and as well as Lown-Gannon-Levine syndrome. And what is the treatment of choice in case of the WPW syndrome? You need to do radio frequency ablation and you need to ablate that accessory pathway, right? Yes. Coming on to the next question. The question is related to the AV block. The question is related to the AV block. Which of the following characteristics is not typically observed in Mobitz type 2, the infranodal AV block? So we are discussing the quick recap of the ECGs here. Which of the following characteristics is typically not observed in Mobitz type 2 or infranodal AV block? Quickly. Right. So the correct answer here is no, it is not B. PR interval conduction is from the SA node to the exit of the AV block. So there is no change. That is a correct statement, right? Very good. So the correct answer is from VPR. So the PR interval is increased is a wrong statement. PR interval in case of Mobitz type 2 AV block, it will be normal. It will be normal PR interval. But what is it you will have? You have intermittent drop in the QRS complexes. Whereas the problem lies below the AV node, it's a correct statement, right? And the PR interval conduction is from SA node to the exit of the AV node. There is no change. That is a correct statement because where exactly is the pathology in Mobitz type 2 AV block? In Mobitz type 2 AV block, the pathology is at this point. The problem is at this point. That is below the AV node. That is in the bundle of S, you have the problem. So the conduction from SA node to the AV node will be normal. There is no problem for the conduction from SA node to the AV node here, right? Then the characteristic feature is that the PR interval before and after the missed beat, they are equal. That's a true statement. I'll show you the ECGs now, right? So this is the ECG of first degree AV block where the PR interval, it is prolonged, right? And this is the ECG, the second degree AV block, Wenckebach's phenomena, that is Mobitz type 1. Okay. So in Mobitz type 1, these patients, they have progressive prolongation of the PR interval. There is progressive prolongation of the PR interval. Then you have a P wave and there is no QRS complex. So that is what is the Mobitz type 1. Whereas in Mobitz type 2, you have a constant PR interval and that too normal PR interval, but you have a P wave and QRS complex is not there. So there is intermittent drop in the QRS complex in case of Mobitz type 2, right? Whereas you take in case of third degree AV block. In third degree AV block, there is no relation between the ventricular complexes QRS and as well as the atrial complexes, that is P wave. So atria will contract independently and ventricles will contract independently. That is what is the discussion related to AV block. AV block is a very, very important part of the discussion related to the ECG, right? Now, in the PDF which I have provided to you, I have given this table, right? You can go through this table. I'm not going to discuss this, right? You can go through that. It is very simplified manner. So this point is what you need to know here. This is a very, very important part of the AV block. The entire questions will be asked on the PR interval story only. Okay. And which type of AV block requires emergency treatment? The emergency treatment, it is for Mobitz type 2 AV block and as well as the complete heart block. These patients will be requiring the pacemaker, right? So that was about the AV block story. Done, right? In the PDF I have provided, the table is there. You can go through that. Now, coming on to the next question. A 35-year-old patient presents in the emergency with sudden onset palpitation His heart rate is 150 beats per minute and gets reverted after the carotid sinus massage. What is the most probable diagnosis? Yeah. See, paroxysmal supraventricular tachycardia is one question which has been repeated very frequently, right? In the last 5 years, if you take the questions, in the last 5 years, almost 3 to 4 times the questions have been asked on the topic of the PSVT, paroxysmal supraventricular tachycardia, right? Let me show you the ECG of PSVT, and I will show you the ECGs of all others as well. Now, this is the ECG of PSVT. What will be the very important feature is, first and foremost, there will be tachycardia. Second important point, there will be narrow QRS complexes. Second important point, they will have narrow QRS complexes. And do you have a P wave? P wave may or may not be present. So P wave, it is merged in the QRS complex, or it will appear after the QRS complex. This will be the ECG in case of the PSVT. Now in PSVT, what is the first line treatment? First line treatment in a patient with stroke. Please answer this question. First line treatment in a patient with stroke. Yes. Right, very good. So in a patient with stroke, that is cerebrovascular accident, don't do your carotid sinus massage. Don't do your carotid sinus massage. You need to give adenosine. Right, you need to give adenosine. But in those individuals where, like for example, so before doing this carotid sinus massage, what is very important? You need to auscultate the carotids. You need to auscultate the carotids. Why? You need to check if there is any presence of the bruit. If there is a bruit, what does that tells you? That there is atherosclerosis of the carotid artery. And when you try to do the carotid sinus massage in a vessel where there is a bruit, that will shower an emboli into the cerebral circulation, causing stroke, right? So before doing carotid sinus massage, you need to check the carotids by auscultation. Okay. Now this vagal maneuvers, basically, what is this? Stimulation of the vagal maneuvers or vagus. Now, can anyone tell me what are the various methods by which the vagus can be activated and the heart rate can be reduced? What are the various methods by which the vagus can be activated and the heart rate can be reduced? Any one of you, please? The various methods where the vagus can be activated and the heart rate can be reduced is, we have a maneuver called modified Valsalva maneuver. This is more effective these days, what we are doing in the emergency department. Then carotid sinus massage. Okay. Then coughing. Then inducing the vomiting, then application of the ice water over the face. Application of the ice water over the face. These are the various methods by which the vagus can be activated and the heart rate can be reduced, right? And adenosine, what is the dosage of the adenosine is? The dosage of the adenosine is 6 milligrams IV. And please remember, whenever you are giving adenosine, you should give adenosine, and that should be followed by the bolus of the IV fluids. Why is that we are giving a bolus of IV fluids? Why? Because the adenosine has a very short half-life. It is there only for a few seconds. So that adenosine should reach the heart immediately. In order to ensure that the adenosine which has been given in the peripheral line to reach the heart, you need to give bolus of IV fluids that will push the adenosine to the heart. Okay. Then, if suppose with 6 milligrams, if there is no response, then you need to give 12 milligrams of the adenosine. And with adenosine, if there is no response, then you need to give the beta blocker. You need to give beta blocker, or you need to give non-dihydropyridine calcium channel blocker. Example of non-dihydropyridine calcium channel blocker will be, right, that will be your verapamil and diltiazem. So verapamil and diltiazem, these are like your non-dihydropyridine calcium channel blocker. And regarding the adenosine, you need to know very important adverse effect. Regarding the adenosine, very important adverse effect is the bronchospasm. That is the reason why it is contraindicated in patients with the bronchial asthma. So this is complete story related to your PSVT, paroxysmal supraventricular tachycardia, right? Then, now, yes. Okay, this is what is your modified Valsalva method, right? Then, yeah, please see this ECG and tell me what is the diagnosis of this ECG. What is the diagnosis of this ECG? Yes, right. So the diagnosis of this particular ECG here is the VT. What type of VT is this? It is monomorphic VT. It is monomorphic VT. Okay. Now, what are the features of the monomorphic VT? Right. The features of monomorphic VT is that the P wave will be absent. The P wave will be absent, and you have wide QRS complexes. And all these QRS complexes, they are of same morphology. They are of same, that is called monomorphic VT. Then how do you treat these patients? If the individual is hemodynamically stable, then the drug of choice will be the amiodarone, right? And if the individual is hemodynamically unstable, then the treatment of choice is the DC shock. The treatment of choice is DC shock. So this is about your VT, ventricular tachycardia, right? Then what is polymorphic ventricular tachycardia? Polymorphic ventricular tachycardia, this is what is nothing but Torsades d pointis, right? Torsades d pointis is nothing but your polymorphic ventricular tachycardia, right? Can anyone identify this ECG? Yes. So this ECG, it is suggestive of the ventricular fibrillation. So how is that you are able to tell it is ventricular fibrillation? So in ventricular fibrillation, there is no identifiable QRS complexes, right? There is no identifiable QRS complexes. That is called ventricular fibrillation, right? And all these patients with ventricular fibrillation, they are hemodynamically unstable. So what will be the treatment of choice in these patients? The treatment of choice is the DC shock. That too, asynchronized DC shock, and the strength of the DC shock, it should be around 360 joules. 360 joules. Okay. So that was the story related to the arrhythmias which I have shown you in the options. Right. Now, answer this question. Which of the following intervention would be the most appropriate as the first line treatment for the rate control of these patients' atrial flutter? Intravenous esmolol, chemical cardioversion with amiodarone, electrical cardioversion with biphasic DC shock, anticoagulation with unfractionated heparin. Right, very good. So always remember, in a case of the atrial fibrillation or atrial flutter, what is very important is rate control should come first. Okay, rate control should come first in the treatment of the atrial flutter or atrial fibrillation. So you need to give intravenous esmolol because that is a beta blocker, right? And that too, it's a short-acting beta blocker. That too, it's a short-acting beta blocker. So that should be the first-line treatment. And followed by that, rhythm control. And how is that? You will be able to do the rhythm control in these patients is rhythm control is being done by the amiodarone. Rhythm control can be done by amiodarone. And it is not just only amiodarone. The other alternative drug that can be given for rhythm control is the ibutylide. Right? Ibutylide is another drug that can be given. Okay. And in atrial flutter, what did I tell you? In atrial flutter, if the individual is hemodynamically unstable, then you can give synchronized DC shock. And this synchronized DC shock, the strength should be around 25 to 50 joules. That is about the atrial flutter. Now you should be able to identify the atrial flutter. Okay. So I show you an ECG. Please tell me the diagnosis. So is this atrial flutter Is it with fixed AV block or is it with variable AV block? Yes, please answer this. Is it with fixed AV block or variable AV block? Yeah, see, there is no doubt. It's an atrial flutter, because in atrial flutter, what is the characteristic manifestation is the presence of sawtooth shaped P waves. Sawtooth shaped P waves. These are the important features. Right? Yeah, so very good. So this is the atrial flutter with variable AV block. Why? Why? Because if you take the RR interval in this ECG, the RR interval, it is not same. It is variable RR interval. Right? So it is variable RR interval. So when there is a variable RR interval with sawtooth shaped P waves, that is atrial flutter with variable AV block. Then please tell me, what is this ECG here? This is the ECG where you are having RR interval, they are same. Right? The RR interval, it is same. So this is the atrial flutter. This is atrial flutter with fixed AV block. Atrial flutter with fixed AV block. Okay. So why? Because RR interval is same. Right? So this is about the story related to the atrial flutter. Right? And one last question on the ECG. One last question on the ECG. And once the ECG is over, then we will move on to the valvular heart diseases. Then we will move on to valvular heart diseases. Yeah, I've just zoomed it. Yes, match the following ECG waves with the time duration. Match the following ECG waves with time duration. Right. So the correct answer, you take P wave. So P wave, you know how much, what is the duration of the P wave? It is less than 120 milliseconds. What is the duration of the Q wave? It is less than 40 milliseconds. What is the duration of the PR interval? It is 120 to 200 milliseconds. And what is the duration of the QRS complex? That is 70 to 90 milliseconds. What is the duration of the QT interval? 360 to 460 milliseconds. Right? Now, you should, no, I did not get the correct answer from any one of you. Yeah, one student. Yeah, VPR has answered it correctly. So the answer is B here. Right? So now if you take the P wave, so it is like less than 120 milliseconds, right? So 40 milliseconds is one small box. 40 milliseconds is one small box. Everyone is aware of this. Okay. So less than 120 milliseconds means how many? 3 small boxes. Right? 3 small boxes. And QRS complex, it is one small box. Okay. And then PR interval. So PR interval, it is 3 to 5 small boxes. Right? Then you take the QRS complex. The QRS complex, it is occupying 70 to 90. So that means it is around 2 to 2.5 small boxes. And QT interval is largest. That is 360 to 460, which is nothing but 9 to 11 small squares. Okay, 9 to 11 small squares. Okay, so this is an integration. Okay, right? First of all, you need to know what is the duration of the individual waves. Second, you should be able to correlate that the waves with the duration over the small boxes. So what is the correct answer here is B. Okay, now you can correlate. What is E? Okay, whatever I have discussed, it is the same thing, right? So, right. So this will definitely take time when you are solving the questions, but when you are used to these type of questions, it is just a fraction of a second which you will be able to solve these type of questions. Okay, so this is about the ECG story. Then we will start with the valvular heart diseases. Right. Which one of the following statement is correct regarding the opening snap in cardiac auscultation? Correct regarding the opening snap in cardiac auscultation. High-pitched sound due to opening of stenosed aortic valve. It indicates pulmonary arterial hypertension. It precedes aortic component of the second heart sound. Yes, I'm waiting for your answer. No. Yes, Bhuwana has answered it correctly. So remember, opening snap, it is a high-pitched sound, right? And it is due to opening of the aortic valve is a wrong statement. The opening snap is due to opening of the mitral valve in the mitral stenosis. And opening of the aortic valve, this will cause ejection click. This will cause ejection click. Okay. And it indicates pulmonary arterial hypertension is wrong. In pulmonary arterial hypertension, the important auscultatory sound is loud P2. And it precedes aortic component is a wrong statement. So it succeeds aortic component. That means after the aortic component A2, then you will have the opening snap. And in fact, A2OS gap, A2OS gap, it tells you about the severity of the mitral stenosis. If A2OS gap is narrow, it is severe mitral stenosis. If A2OS gap is wide, it is mild mitral stenosis. Okay. So now what is that? We will quickly revise now. We will quickly revise about the mitral stenosis. Okay. So what is the normal mitral valve area? The normal mitral valve area is around 4 to 6 centimeters square is a normal mitral valve area. What is the most common cause of mitral stenosis? That is the rheumatic heart disease. And we have a storage disorder that will be causing mitral stenosis, that is the Hurler syndrome. Right? That is Hurler syndrome, where there is accumulation of mucopolysaccharides. So there is mucopolysaccharidosis in case of Hurler syndrome. That's a storage disorder that can cause MS. And we have a connective tissue disorder that will cause MS, that is rheumatoid arthritis and as well as systemic lupus erythematosus. Then how will you, okay, this is like, how will you classify mild? We don't have moderate, severe and very severe. Okay, mild, moderate and very severe. We use this word mild when the valve area is less than 2 centimeters square. Okay, 1.5 to 2, right? 1.5 to 2 is mild mitral stenosis, whereas 1 to 1.5 centimeters square is severe mitral stenosis. And when the valve area is less than 1 centimeter square, that is severe, very severe mitral stenosis. And what will be the clinical manifestation in these patients is dyspnea. Why? Because of the development of pulmonary edema, there will be dyspnea. Right? The forward flow of the blood from left atrium to left ventricle does not occur. There is reversal of the flow from left atrium to the lungs, resulting in pulmonary edema. Now the question comes, why there is palpitations? Why? Because the left atria is enlarged. This enlarged left atria, these patients, they are at risk of development of atrial fibrillation. That is the reason why you'll have palpitations. Then apical impulse in mitral stenosis, it is tapping type of apical impulse. Then what is the abnormal heart sounds that you will have is the S1 will be loud in mitral stenosis. But the question comes, mitral stenosis with soft S1, where do you have this? If suppose, if it is calcific mitral stenosis, then you will have mitral stenosis with soft S1, right? Then another important auscultatory finding is opening snap. Opening snap, that is due to opening of the stenosed mitral valve. And you will have a murmur, that is mid-diastolic murmur, which is a low-pitched murmur. And where is it best heard? It is best heard at the apex. And because it's a low pitch, it is heard with the bell of the stethoscope. And there is no radiation of this murmur. And ECG will show you P wave as M shape. This we call it as P mitral, where the duration of the P wave is increased. Chest X-ray will show you that there is straight left heart border and double density sign. Double density sign is mainly because, so both of these double density sign. So both straight left heart border and as well as the double density sign, both of them, they are due to left atrial enlargement. And what exactly is the first line investigation or investigation of choice is 2D echo. 2D echo, you have what is called as the hockey stick appearance. Why do you get this hockey stick appearance? This particular hockey stick appearance, that is due to restricted mobility of anterior mitral leaflet. You will have the hockey stick appearance on 2D echo. What is the treatment? Medical management is that you need to give beta blocker right? And the intervention in very severe mitral stenosis, you can do PBMV, that is percutaneous balloon mitral valvotomy. And if there is any contraindication for PBMV, what is the contraindication for PBMV? Calcific mitral stenosis, presence of left atrial thrombus. These are like contraindications for PBMV. And whenever there is contraindication to PBMV, then you need to do mitral valve replacement. Right? You need to do mitral valve replacement whenever there is contraindication. So this is about the story related to the mitral stenosis. Okay. Now, I'll show you one important question and let me see how many of you can answer this. How does the left ventricular hemodynamics in a patient with acute onset shortness of breath and severe mitral regurgitation will be? How does the left ventricular hemodynamics in a patient with acute onset shortness of breath and severe mitral regurgitation will be? So we are done with the MS. Now I am discussing MR. I will discuss MR, okay? Right. Let me see how many of you can answer. It's not an easy one, but very good, excellent. So I'm getting the correct answers from Vicky and as well as your drug of choice. Okay, right. So the correct answer here is B. The correct answer here is B, right? Why? Why the answer being B? Let me explain to you. There is decrease in the afterload, increase in the preload, and as well as ejection fraction increases. So in case of the mitral regurgitation, okay, I'll just draw this image of the left side of the heart so that for you to understand it in better manner. So this is the left atrium and left ventricle. Okay. Now, what is afterload? Afterload is the pressure which is exerted by the aorta on the left ventricle. Now, in mitral regurgitation, when the left ventricle is contracting, some amount of blood is entering into the aorta and some amount of blood is entering into the left atrium. So, the amount of blood which is moving from left ventricle to the aorta, it is decreased. Thereby, what will happen to the afterload? Afterload also will be decreased because the amount of blood which is entering into the aorta is less. So the pressure which is exerted by the aorta on the left ventricle is also less. So afterload is reduced. Then you take preload. Preload will be increased. Why? Because the left ventricle, whenever it is receiving the blood, it will receive the left atrial blood and it will also receive the mitral regurgitant blood. So the preload is increased in the mitral regurgitation. Then what will happen to the ejection fraction? Ejection fraction, it is increased. What exactly is the ejection fraction? Ejection fraction is the percentage of the blood that is pumped out of the left ventricle. So when preload is increased, the ejection fraction also increases. Because the end diastolic volume will be increased in patients with the MR. When end diastolic volume is increased in MR, whenever the left ventricle contracts, more amount of the blood will try to enter into the aorta after a while, not in early stages. After the mitral regurgitation is progressing, the ejection fraction increases. Okay, so this is right. So this is about the hemodynamics in patients with MR. Very, very important question. Afterload decreases, preload increases, ejection fraction increases. Right? Then. Now, let me just quickly recap the topic of MR. So MR, it is the disorder where you have regurgitation of the blood from the left ventricle to the left atrium during LV contraction. Now, what are the causes for acute MR? The causes for acute MR will be papillary muscle rupture that can happen in patients with myocardial infarction. Then valve perforation that can happen in patients with the infective endocarditis. Then the another cause for acute MR is rupture of the chordae tendineae. Okay, papillary muscle rupture, chordae tendineae rupture, and valve perforation in infective endocarditis. And these patients, they will be requiring immediate surgery. These patients, they will be requiring immediate surgery. Then what are the chronic causes for MR? The chronic causes for MR will be rheumatic heart disease. Right? The clinical features in patients with MR will be palpitations. Why? Because there is left ventricular dilatation. And how will be the apical impulse in patients with MR? It is hyperdynamic type of apical impulse in case of MR. And how will be the cardiac murmur in MR? In cardiac murmur in MR, it will be pansystolic murmur, and this pansystolic murmur is heard at the apex, and that will be radiating to the axilla, right? Then what will be the abnormal heart sounds? The S1 will be soft because your mitral valve is not closing completely. The S1 will be soft. And whenever there is development of left ventricular failure, they will have S3 and as well as S4. And Carey-Combs murmur, it is a mid-diastolic murmur, which is heard in acute MR. And it is a functional murmur. And what is the investigation of choice in case of, and where will you have acute MR? You can have that in case of acute rheumatic carditis. Acute rheumatic carditis. Okay. Investigation of choice will be the 2D echo. The treatment will be similar to that of like what we give in heart failure. What will be that? Beta blockers. Then the AC inhibitors, right? Or ARBs. Aldosterone antagonists. And in severe MR, these patients will be requiring mitral valve replacement. So that is about the story related to MR, mitral regurgitation. Yeah, we also give diuretics whenever there is development of pulmonary edema. So when there is pulmonary edema causing shortness of breath, then you need to give diuretics. So that is about the story related to the MR. Okay, then, yes, you see this next question. A 65-year-old male presents to the clinic due to shortness of breath on exertion, chest pain, and occasional fainting episodes. His blood pressure is elevated. Cardiac auscultation reveals narrow split second heart sound. A murmur is heard over the right upper sternal border. Which of the following murmur would be found in this patient? Yeah, yes, Dr. Vicky. In severe MR, you will have mid-diastolic murmur. That is what I was telling you, that Carey-Combs murmur is nothing but mid-diastolic murmur. Okay, right. Very good, Bhuvana Raghu. So what is the clinical diagnosis of this patient? The clinical diagnosis of this patient is the aortic stenosis. How can you say that it is aortic stenosis? First is elderly patient. Valvular abnormality in elderly individual is more common is aortic stenosis. It can be anything, but more common is aortic stenosis. Then dyspnea, fainting episode, chest pain. Dyspnea, fainting episode, and chest pain. So all these three are seen in case of aortic stenosis. And in aortic stenosis, the blood pressure, it can be variable. It can be variable. Okay. So S2, they'll have narrow split. And the murmur is heard in the aortic area. And what is the murmur that you have in case of aortic stenosis? That is ejection systolic murmur, which is also nothing but a mid-systolic murmur. Which is nothing but mid-systolic murmur. And which is your mid-systolic murmur here? The first option. Can anyone tell me what is a murmur in second option? Yes, can anyone tell me what is a murmur in the second option? That is option B. What is a murmur? Option B, what is a murmur? So you have the murmur which is heard throughout the systole. So option B, it is suggestive of pansystolic murmur, which is heard in MR, which is heard in VSD, which is heard in TR. Okay. Now, can anyone tell me what is option C? What is option C? Right. So option C, you have a mid-systolic click. Right. You have a mid-systolic click with late systolic murmur. So mid-systolic click with late systolic murmur. Where will you have this? Very good, Vasif, and as well as Sajan. That is mitral valve prolapse syndrome. Mitral valve prolapse syndrome. Okay. Now, yeah. Can anyone tell me? Yeah, you are having opening snap. Opening snap is suggestive of what? Mitral stenosis. In mitral stenosis, you have this opening snap, right? Then, now we will do the quick revision of the aortic stenosis. Quick revision of the aortic stenosis. So, what is the normal aortic valve area? In 1 minute, I will revise. Okay. Normal aortic valve area is 3 to 4 centimeters square. When do you call aortic stenosis? When the valve area is less than 2 centimeters square, we call it as aortic stenosis. And in mild aortic stenosis, the valve area is less than 2. Moderate, it is 1 to 1.5 centimeters square. In severe, the valve area is less than 1 centimeter square. Then what is the most common cause of aortic stenosis in children? That is bicuspid aortic valve. What is the most common cause of aortic stenosis in adults? That is calcific aortic stenosis. What will be the clinical feature in case of aortic stenosis? Angina, then syncopal attack, then dyspnea. Okay, so you can just remember this mnemonic as ASD. All right. Then what is the characteristic pulse? The characteristic pulse will be these patients, they will have pulses parvus et tardus. Pulses parvus et tardus. Okay. So pulses parvus et tardus is that where you have, right? It is the pulse, slow rising pulse with late peaking. Slow rising pulse with late peaking. Blood pressure, systolic blood pressure, it will get reduced. Apical impulse in aortic stenosis, it is heaving type of apical impulse. And carotids, you will have a carotid thrill. And heart sounds, if you observe, A2 will be soft. And you have a narrow split S2. And what is the additional heart sound that you will listen in aortic stenosis? You will listen S4. And what is the characteristic murmur? It is ejection systolic murmur, which is heard in the aortic area. Yeah, this is nothing but your crescendo, decrescendo murmur, right? And where is it heard best? In the aortic area, and it will radiate to the apex. And when it is radiating to the apex, this we call it as Gallowerdin phenomena. This is called Gallowerdin phenomena, right? And the investigation of choice will be the 2D echo, which will assess the valve area. What does the ECG show? The ECG will show you that there is left ventricular hypertrophy. And all the cases of the aortic stenosis, symptomatic aortic stenosis, you need to do aortic valve replacement. You need to do aortic valve replacement. Okay, so that was about the story related to aortic stenosis. Then we will move on to the next question. Which of the following is unrelated to women's exertional dyspnea, chest discomfort, well-controlled hypertension, a systolic murmur heard over the right upper sternal border? The question is, which of the following is unrelated? Which of the following is unrelated? Turner syndrome, rheumatic heart disease, Notch3 gene, Shown complex. First of all, can anyone tell me what is the diagnosis? Yes, Bhuvana Raghu, what is the diagnosis? What is the diagnosis? Diagnosis here is again the aortic stenosis, right? Aortic stenosis. So Turner syndrome can cause aortic stenosis. Your rheumatic heart disease can cause aortic stenosis. Shown complex. What is this Shown complex? Shown complex is nothing but it is a congenital disorder, right? It's a congenital disorder where you will have subvalvular aortic stenosis. Right? Subvalvular aortic stenosis. And not only subvalvular aortic stenosis, these patients with Shown complex, the mitral valve is also abnormal. And this we call it as the parachute mitral valve, right? And there is also a mitral membrane. And this mitral membrane is supravalvular mitral membrane. And what is Notch3? The answer is actually Notch3. What is Notch3? Notch3 is the scenario. Notch3 gene is being associated with what is called CADASIL. What is CADASIL? CADASIL, it stands for cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. I'll repeat again. Cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. Basically, it's a small vessel disease. It's a small vessel disease of cerebral blood vessels. Right? It's a small vessel disease of the cerebral blood vessels. That is what is your Notch3 gene being defective. Okay. So that was the story of the Notch3. One more question on AS. A known case of aortic stenosis with progressive narrowing of the valve belongs to which stage of the aortic stenosis? Stage A, stage B, stage C, stage D. Yes. Right. So you have stages of the aortic stenosis. What are the stages of the aortic stenosis? Is that in stage A, the patient will have the risk factors for aortic stenosis, risk factors for the aortic stenosis, but there is no aortic stenosis. Stage B is that actually the answer here is stage B. Stage B is progressive narrowing of the aortic valve, right? And stage C is that these patients, they will have severe aortic stenosis, but they are asymptomatic, right? Stage D is that these patients, they will have severe aortic stenosis. Along with that, you have the symptoms. That is what is your stage D aortic stenosis. Okay, so these are the stages of the aortic stenosis. If it is progressive narrowing, if this word is mentioned, then it becomes stage B aortic stenosis, right? Now, that was the story related to AS. Now, the next question is related to AR. Now, okay, I will give you 1 minute time for this because you have 7 points here, and you should be able to match these 7 points with A, B, C, D, E, F, G. Okay, so basically what are these? These are all the peripheral signs in AR. These are all peripheral signs in AR. And you don't have these peripheral signs in acute AR. Yeah, very good. So we have the correct answer coming from the Shravanti Kodali and as well as Sunil Acharya. So the correct answer here is D, right? What exactly is this? Let me just tell you quickly. Now you take Landolfi's sign. Landolfi's sign is the pulsations within the pupil. Then Rosenbach's sign, that is the pulsations over the liver. Then Corrigan's sign. Corrigan's sign is now Gerhardt sign. What is Gerhardt sign? Gerhardt sign is the pulsations over the spleen. Then you have the Durosi's sign. So Durosi's sign, it is the murmur which occurs after gently pressing over the femoral artery. Then you have the Corrigan's pulse. Corrigan's pulse, it is, right, you have, yeah. So obliteration of the radial artery and elevate the arm. So basically that water hammer pulse. Muller sign. What is this? This is over the uvula, pulsations over the uvula. Then Demosette sign. That is head nodding with each cardiac cycle. Head nodding with each cardiac cycle. Okay. Right. Great. So yes. So all the students have almost answered. And peripheral signs in AR, that can be asked. Right. You need to be aware of it. And all the peripheral signs you will have only in chronic AR, and you don't have these peripheral signs in acute AR. Then what will be the clinical features in case of AR? The clinical features in AR will be palpitations. Why? Because there is left ventricular dilatation in these patients. Because of that, there will be ventricular ectopics causing the palpitations. Okay, and the apical impulse will be hyperdynamic type of apical impulse because the left ventricle is dilated. And the same hyperdynamic type of apical impulse is observed even in case of MR. And abnormal heart sound that you will have is the A2 will be soft. The A2 will be soft. Why? Because the aortic valve is not getting closed, so the A2 will be soft. And what is a characteristic murmur here? The characteristic murmur will be the early diastolic murmur. Then what is Austin Flint murmur? That is mid-diastolic murmur that is heard in case of the severe AR. And that is due to functional mitral stenosis. And you also have ejection systolic murmur, but this is also the functional murmur. And that is due to increased stroke volume. What is Cole-Cecil murmur? That is the early diastolic murmur will be radiating to the axilla. That is what is called as the Cole-Cecil murmur. That is what is nothing but your Cole-Cecil murmur. Wasif, you will have wide split S2. No, you don't have wide split S2 here. The A2 will be soft or A2 is not heard at all. A2 is not heard at all. Why? Because the aortic valve is not closing. When aortic valve is not closing in the AR, the A2 is not heard. Where will you have wide split S2? You will have wide split S2 in VSD. You will have wide split S2 in MR. Okay. I'll be discussing that. I'll be discussing about the wide split S2 here, right? Okay. Now, coming to the next important question. Right. We have a 42-year-old female presents to the clinic due to occasional palpitations, mild exertional shortness of breath, and chest discomfort. Her blood pressure is 120/80, heart rate is 82 and regular. Mid systolic click at the apex, followed by late systolic murmur. The murmur increases in intensity with Valsalva maneuver and decreases with squatting. Which of the following additional finding cannot be found in this patient? Cannot be found in this patient. Yes, very good, Sunil Acharya. So the diagnosis is mitral valve prolapse. Diagnosis is mitral valve prolapse. You see the question properly. Cannot be found in the patient. Cannot be found in the patient is what is being asked. Very good. So the correct answer is from Vasif and Sajan. So the answer is sacroiliitis. Now, what are all the various etiologies where you will have the mitral valve prolapse? The most common cause of mitral valve prolapse is idiopathic. We don't know what exactly is the cause. The other causes will be Marfan syndrome, where you have abnormality in fibrillin gene. The other important cause will be the Ehlers-Danlos syndrome, where you will have the hyperextended joints in both of them, right? And the another important etiology for mitral valve prolapse syndrome is osteogenesis imperfecta. Osteogenesis imperfecta, you will have Brugsch. But remember, sacroiliitis, you don't have aortic regurgitation. Sorry, mitral valve prolapse is not observed in sacroiliitis. Sacroiliitis is the one which will cause the AR. Sacroiliitis is seen in where it is observed in ankylosing spondylitis. Right, ankylosing spondylitis, it is one of the important etiology, right? Ankylosing spondylitis, it is one of the important etiology that will be causing AR. That will be causing AR, right? Not the mitral valve prolapse syndrome. Then what are the other causes for mitral valve prolapse syndrome? The other causes for mitral valve prolapse syndrome, it includes the rheumatic heart disease, and it also includes subacute bacterial endocarditis. These are all the various causes for the mitral valve prolapse syndrome. Okay, so the answer here is sacroiliitis is not observed. Done? Then coming on to the next question. Yes, with this, your valvular heart diseases are over. Your valvular heart diseases are over. Okay, then we will move on to the cardiomyopathies. A 35-year-old laborer consulted a local medical practitioner for recurrent attack of chest pain. His elder brother said similar complaints and died at the age of 40 years. The laborer was advised to take sublingual nitrate at the time of chest pain, but after taking nitrate, the chest pain increased in intensity. Which of the following is the most likely diagnosis in this patient? Right, very good, Vicky. So the answer is the hypertrophic obstructive cardiomyopathy. So please remember, in patients with hypertrophic obstructive cardiomyopathy, whenever you give, in patients with hypertrophic obstructive cardiomyopathy, whenever you give nitrates, okay, or whenever you give diuretics, what will happen? There will be decrease in the preload. Once there is decrease in the preload, there will be decrease in the LV volume. Once there is decrease in LV volume in HOCM, the obstruction increases. When obstruction increases, cardiac output decreases. So myocardial perfusion decreases, and that will cause the precipitation of angina. So please remember, in patients with, so these are all the drugs which are contraindicated. Nitrates and as well as the diuretics are contraindicated. And not only nitrates and as well as diuretics. Hey, Vicky, why you said amlodipine? Amlodipine is not contraindicated. Calcium channel blockers are not contraindicated in case of your HOCM. The other drugs which are contraindicated are digoxin. And the other drugs which are contraindicated are the sympathomimetic amines. Sympathomimetic amines. These are contraindicated in case of the HOCM. Okay. And not only that, what is another point telling you that it is HOCM? The elder brother had a similar complaint and died at the age of 40 years. Okay, so your HOCM, it is an inherited disorder where you have autosomal dominant type of inheritance, where you will have autosomal dominant type of inheritance. Whereas in aortic dissection, what will be the pain? What will be the clinical feature? Tearing type of chest pain will be there. And in mitral regurgitation, just now we have discussed, they will have palpitations. And in subacute bacterial endocarditis, they will have fever. They'll have fever. Okay, right. I'll discuss about the HOCM in detail subsequently. Right. A patient with atrial fibrillation on regular treatment presents with photosensitivity, skin discoloration, and peripheral neuropathy. Which drug may be implicated in this? Digoxin, disopyramide, amiodarone, then bisoprolol. Very good VPR. So the correct answer is the amiodarone. Amiodarone, it is associated with all these adverse effects: photosensitivity, skin discoloration, and as well as the peripheral neuropathy. And what is this? What is the color of the skin in case of the amiodarone toxicity? That is bluish gray discoloration. Right? That will be bluish gray discoloration. That is what you will observe in case of the amiodarone toxicity. Right? Okay. So now, so what was this topic actually? This topic is the atrial fibrillation. So in case of atrial fibrillation, if you take the etiology of atrial fibrillation, so like you have a mnemonic. The mnemonic is atrial fib. Okay. Now I'll just show you all the etiologies. Okay. A stands for the alcohol abuse, right? T stands for thyrotoxicosis. R stands for the rheumatic heart disease. I stands for ischemic heart disease. A stands for atrial septal defect or atrial myxoma. L stands for lung pathologies like pulmonary embolism. PH stands for pheochromocytoma. I stands for idiopathic, we don't know what exactly is the cause. And even cardiomyopathies like dilated cardiomyopathy can also cause AF. And B stands for the blood pressure. That is hypertension. So hypertension is the most common cause for the atrial fibrillation. Then how is that you will treat the atrial fibrillation? So the treatment of atrial fibrillation is same. Rate control is first. And how is that you will achieve the rate control? You will achieve the rate control with beta blockers or the calcium channel blockers. Then anti-arrhythmic drugs. And in the anti-arrhythmic drugs, what are very important? The very important are the the amiodarone. And one more important is the ibutylide. And lastly, antiplatelets or anticoagulants should be given. So the antiplatelets or anticoagulants that we need to give is decided by what? That is decided by CHA2DS2 VAS scoring system. That is decided by CHA2DS2 VAS scoring system. Okay. Now, what is this CHA2DS2 VAS scoring system? C stands for congestive heart failure. H stands for hypertension. Then A stands for age of the individual more than 75 years. If it is there, give a score of 2. If congestive heart failure is there, give a score of 1. Hypertension is there, give a score of 1. D stands for diabetes mellitus, give a score of 1. S stands for stroke. If stroke is there, give a score of 2. V is there stands for the vascular disease. If it is there, give a score of 1. Age of the individual, if it is more than 65 years, give a score of 1. Right? And the SC stands for, that is sex, gender. If the female patient is there, give a score of 1. Okay. So in this CHA2DS2 VAS scoring system, if the score is 0, either no antiplatelet is required or you can give antiplatelet. Either of this is fine. If the score is 1, then you need to give antiplatelets or anticoagulants. And if the score is like more than or equal to 2, then you need to give anticoagulants. That is about your CHA2DS2 VAS scoring system. Right? Right. Yeah. Sunil Acharya is telling about the Hess-Bled score. What is Hess-Bled score? The Hess-Bled score, we check in individuals in whom you have started the anticoagulant. And the Hess-Bled score will tell you about the severity of the bleeding. Right? It will tell you about the severity of the bleeding. That is about the importance of the Hess-Bled score. Right? So that is about the story of atrial fibrillation. Yeah, which one of the following produce loud S1 on cardiac auscultation? Which one of the following will produce loud S1 on cardiac auscultation? Anemia, pregnancy, thyrotoxicosis, mitral regurgitation. Yes. So, great, great. So the answer is 1, 2, and 3. Whereas in mitral regurgitation, you will have soft S1. You will have soft S1. So if you take the first heart sound, if you take the frequency of the first heart sound is, it is medium to high frequency sound. Medium to high frequency sound. And what will be the duration of the first heart sound? The duration of the first heart sound, it is around 0.14 seconds. Okay. And between, you have two components in first heart sound, M1 and T1. Between M1 and T1, there is no split. Like between A2 and P2, you have a split. There is no split here. Why? Because the duration between M1 and T1, it is just only 20 to 30 milliseconds. That is the reason why there is no split. And what are the conditions where you will have soft S1? Soft S1, you will have that in case of MR and TR. And you will have that in emphysema, that is COPD. You will have that in pericardial effusion and as well as left-sided pleural effusion, and then prolonged PR interval. Okay, so these are all the conditions where you will have soft S1. Then what are the conditions where you will have loud S1? All the hyperkinetic states. What are your hyperkinetic states? That includes anemia, thyrotoxicosis, beriberi, AV fistula, pregnancy, Paget's disease of bone, fever. Then short PR interval. Right, then short PR interval. There also you will have loud S1. So this is about the conditions where you have soft S1 and next is MS and TS. These are the conditions related to the abnormality of the first heart sound, right? Then coming to the next question, right? This again a repeat one. Left atrial dilatation on the X-ray is characterized by which of the following? Left atrial dilatation on X-ray is characterized by which of the following? Straight left heart border, rounding of left heart border, double cardiac shadow, widening of the angle of carina. No, Sunil Acharya, you are wrong. Rounding of the left heart border will not be there. Rounding of the left heart border will not be there. Okay. So you have straight left heart border, you have double cardiac shadow, and you have widening of the carina as well. What is that? I'll show you. What is that widening of the carina? I will discuss and I will show you. Okay. So this is the normal chest X-ray. Right. This is the normal chest X-ray. And you take the left heart border, you have the curvature in the left heart border. It is not straight. It is not straight. But in patients with the mitral stenosis, you have a straight left heart border. Why is that? That is because of left atrial enlargement. Then the question comes, what is carina? Carina is a bifurcation of the trachea. Okay, so this is the right main bronchus and this is the left main bronchus. And this is what is your carina. So there will be widening of the carina. Why is that there is widening of the carina? That is because of the left atrial enlargement, which will separate the main bronchus. Okay. And next is your double density sign. You can see that. This is the shadow of left atrium, and this is the shadow of the right atrium. And this is what is called double density sign, which is observed in case of the mitral stenosis. Okay. So this is the X-ray basically of mitral stenosis, right? Then I was discussing in mitral stenosis, you have what is called hockey stick sign. Why is this hockey stick sign? That is due to restricted mobility of the anterior mitral leaflet. Okay, restricted mobility of the anterior mitral leaflet. That will be causing the hockey stick sign, right? Done. We are done with that X-ray story. Yes, we'll see the next question. We have a 30-year-old male is being evaluated for shortness of breath. On examination, jugular venous pressure, right? That is JVP is increased on inspiration. Now the question is, which of the following is the most likely diagnosis in this patient? Constrictive pericarditis, the atrial septal defect, aortic regurgitation, severe mitral stenosis. Right, great. So the correct answer here is the constrictive pericarditis, right? So within 1 minute, I will revise the entire constrictive pericarditis, right? Are you people ready for that? Yes. Now, in constrictive pericarditis, what exactly is the problem? There is calcification of the pericardium and thickening of the pericardium, right? Then what is the most common cause for constrictive pericarditis? The most common cause for constrictive pericarditis is it is the sequelae of the pyopericardium. It is a sequelae of the pyopericardium that will be causing the constrictive pericarditis. Then what are the other causes? The other causes will be the tuberculosis. The other causes will be trauma. The other causes will be your mediastinal irradiation. These are the other causes for constrictive pericarditis. Then what is the pathophysiology in constrictive pericarditis? That is diastolic dysfunction. Why there is diastolic dysfunction? Because pericardium is like thick and calcified and the pericardium is unable to relax. The clinical features that you will have is both right heart failure features will be there and left heart failure features will be there. And what will happen to the JVP? JVP, it is elevated, right? And these patients will have the Kussmaul sign. What is that? The increase in JVP on inspiration. Normally on inspiration, JVP should fall down. But in these patients with constrictive pericarditis, there will be increase in JVP on inspiration. And there will be also deep X and as well as Y descent. And on auscultation, along with first and second heart sound, you will have an additional sound here. And that additional sound that you will have in these patients will be pericardial knock. And this pericardial knock, it is a diastolic sound, right? And it is a high-pitched sound. Then what does the X-ray show? X-ray will show you that there is calcification of the pericardium. What does the 2D echo show? The 2D echo will show you that there is a septal bounce during inspiration and expiration. What does the ECG show? ECG shows there will be low voltage complexes, right? ECG show low voltage complexes. And CT and MRI will demonstrate the thickness of the pericardium. And how much should be the thickness of the pericardium? It should be more than 4 mm. What is the treatment? The treatment is you need to give diuretics. And if the individual is refractory to medical management, then you need to do pericardiectomy, right? Then you need to do pericardiectomy. So this is about your constrictive pericarditis story. Now, let me show you the images related to constrictive pericarditis. Okay, right. Now, when you do a cardiac catheterization, the cardiac catheterization in constrictive pericarditis will show you what is called the square root sign. What is the square root sign? Basically, these are the changes within the ventricle, that is ventricular pressure changes by cardiac catheterization. Okay, so this is about the constrictive pericarditis. And in constrictive pericarditis, you can observe the pericardium, it is thick and calcified. And how much that is thick and calcified? More than 4 mm. And you can see low voltage complexes. What is the criteria for low voltage complexes? That is, the QRS complex will be less than 10 mm in the chest leads and less than 5 mm in the limb leads, right? Then the chest X-ray will show you that there is presence of the cardiac calcification. You can observe that on the AP view and you can observe that even on the lateral view, right? Now, this is what is your septal bounce. This is what is your septal bounce in case of constrictive pericarditis. What is that? During inspiration, the interventricular septum is pushed onto the left. During expiration, the interventricular septum is being pushed onto the right. Okay. Then this will be the imaging where you have the demonstration of the pericardium of more than 4 mm. Okay. That can be demonstrated on CT or the MRI. Right. So that was the story related to the CP, that is constrictive pericarditis. Done. Next, coming on to the next question. We have a 24-year-old man presents with acute onset shortness of breath with precordial chest pain. ECG shows ST segment elevation with upward concavity, PR segment depression in V2 to V6, reciprocal changes in lead AVR. What do you think is the most likely diagnosis? Yes, acute wall MI, acute pericarditis, anterior wall aneurysm, aortic dissection. Great. So the answer is the acute pericarditis here. So in acute pericarditis, I have already discussed this. You will have a global ST segment elevation. You will have a global ST segment elevation. And that too, this ST segment elevation, it will be concave ST segment elevation in all the leads. Except in AVR, you will have ST segment depression. Okay. But in anterior wall MI, you will have ST segment elevation only in V1 to V4. Right? And in case of anterior wall aneurysm, you have tomb-shaped ST segment elevation. This already I have discussed. And in aortic dissection, the dissection can progress to coronary artery. Once the dissection progresses to the coronary artery, these patients will develop MI. And depending upon which coronary artery the dissection is there, accordingly, you will have the ECG changes. Okay. Now, let me do a quick recap. Within 1 minute, I will quickly revise the acute pericarditis. What is the most common cause of the acute pericarditis is it is idiopathic. But if you take the known causes, that includes the viral infection. And what is that viral infection? That includes actually we have two viruses, Coxsackie virus and ecovirus. But the most common will be Coxsackie virus, then ecovirus in causing the acute pericarditis, right? And the other infections include the bacterial infections like tuberculosis and as well as the streptococcus pneumonia. And in patients with the acute pericarditis, you will have a diagnostic triad. What is the diagnostic triad? You will have chest pain, that is pleuritic type of chest pain, which will increase on inspiration. And wherever you auscultate over the chest, you will be able to listen the pericardial rub. And ECG will show you that there is ST segment elevation. And what does the 2D echo show? There can be pericardial effusion that can be observed on the 2D echo. And what is that you will give in the treatment? Because it's an inflammatory pathology, you need to give anti-inflammatory drugs. And the complications which are associated with acute pericarditis is there can be development of pericardial effusion, right? Or this can progress to the development of the constrictive pericarditis also. Constrictive pericarditis also. Okay. So that is about your quick discussion related to the acute pericarditis, right? We are done with the acute pericarditis. And one more option like we were discussing was the aortic dissection here. Now, I will just revise the aortic dissection in just 1 minute. Okay, in 1 minute, I will revise the aortic dissection. Right. So aortic dissection, what exactly is the problem? The problem is that these patients, they will have intimal tear and there will be seeping of the blood into the tunica media, resulting in the false lumen. False lumen. That is the definition of the aortic dissection. And the most common risk factor for the development of aortic dissection will be the hypertension. Actually, we have many other risk factors like Marfan syndrome, Ehlers-Danlos syndrome, large vessel vasculitis like Takayasu arthritis, then giant cell arthritis. All these are the other causes for aortic dissection, right? Then, how do you classify the aortic dissection? Is by Stanford and DeBakey. But if you take Stanford, it is little easy. According to Stanford, you have type A and type B. So type A is that where the aortic dissection is in the ascending aorta and as well as the arch of aorta. Whereas type B dissection is that it is the dissection which is present in the descending part. So distal to the left subclavian artery, if you have the dissection, then we call it as the type B. But which is more dangerous? More dangerous is the type A dissection. Okay, what will be the clinical feature? That will be chest pain. And this particular chest pain in case of aortic dissection, it will be central and that will be radiating to the back between the two scapular blades. And it is a tearing type of chest pain. And the complications these patients can develop is the aortic regurgitation can be there. There can be development of cardiac tamponade. There can be development of the coronary artery disease. And there can be even rupture of the false lumen resulting in the vascular shock. Okay, so this will be the complication. And investigation of choice, what exactly is the investigation is the MRI. But in acute cases, you cannot do MRI. Then in such case, we do CT aortogram. Then the medical management is that drug of choice will be the esmolol. But esmolol is not being available very frequently. So the alternative drug that we give is labetalol, which is both alpha plus beta blocker. And by giving this labetalol, what is the advantages it is? You need to control the blood pressure where the systolic blood pressure should be around 100 to 120, right? And your heart rate, it should be around 60 to 70 per minute. That should be your target whenever you are giving the medical management. And surgical treatment, if you observe, and what are the drugs which are contraindicated in case of aortic dissection? The drugs which are contraindicated in aortic dissection will be hydralazine is contraindicated. And one more drug that is contraindicated is digoxin. Because these two drugs, what they will do, they will increase the hydraulic shear and that will propagate the dissection. So that is the reason why these two drugs are contraindicated, right? And surgical treatment or surgical intervention, it is required in all the type A dissections. In all the type A dissections, the surgical intervention is required because the type A dissections, they are very dangerous, very, very dangerous because that will be involving coronary artery. That will be involving the arch of aorta, where you have common carotid artery which is originating there. Okay, so this is about the story related to the aortic dissection, right? Now we'll move on to the next. Yeah, so this is your type A dissection where you have the involvement of the ascending aorta and as well as the arch, right? So type B dissections are those which are distal to the left subclavian artery. Distal to the left subclavian artery. This will be your type B dissection, right? Yeah, cardiac tamponade, I've said. The complication is cardiac tamponade. Yes, answer this. Thickened ventricular wall with normal diastolic function is a feature of hypertrophic cardiomyopathy, restrictive cardiomyopathy, endomyocardial fibrosis, and athlete's heart. Very good. Vicky, see, all these will cause diastolic dysfunction. All these disorders will cause diastolic dysfunction. But if you take the athlete's heart, there will not be diastolic dysfunction. There will be normal diastolic function in case of the athlete's heart, but there is the thickened left ventricle. But there will be thickened left ventricle. Okay. Now, so I was discussing about, now I'll just do a quick recap of HOCM and restrictive cardiomyopathy, right? 1.5 minutes for HOCM, 1.5 minutes for the restrictive cardiomyopathy. Okay. Right. You take HOCM. HOCM, it is a disorder where you have diastolic dysfunction, and this will cause heart failure with preserved ejection fraction, where the ejection fraction will be more than 50%. And in order to call it as HOCM or hypertrophic cardiomyopathy, the thickness of the ventricular wall, it should be more than 1.5 centimeter. And whenever there is septal hypertrophy, we call it as HOCM because there is an obstruction to the left ventricular outflow tract. And if there is apical hypertrophy, we use the term called the HCMP, right? It is not called HOCM there. And in septal hypertrophy, the left ventricle lumen, it will be banana-shaped left ventricle lumen. LV lumen will be banana-shaped. Whereas in apical hypertrophy, the LV lumen, it is the shape of the LV lumen is of the ace of spades. And what is the most common gene that is being mutated? It is the beta-myosin gene, which is present on the chromosome 14. Okay, actually there are almost more than 100 genes being mutated, but the most common gene that is being mutated is beta-myosin gene. And the other proteins which are being defective, are the troponin T and as well as myosin binding protein C, right? Myosin binding protein C. Okay, and what will be the clinical feature? Most of the times they are asymptomatic and they directly present with sudden cardiac death on exertion. Okay, and if at all, if they are symptomatic, what will be the common symptom is dyspnea, and that is because of the development of pulmonary edema. And on examination in patients with the hypertrophic cardiomyopathy, the characteristic pulse is the pulsus bispherians. Okay, pulsus bispherians, right? And if you take the carotid, you will have double carotid upstroke, right? Double carotid upstroke. And how will be the apical impulse? That will be double apical impulse. And what is the characteristic murmur? It is ejection systolic murmur, okay, or mid systolic murmur. Then ECG will show you that there is left ventricular hypertrophy, and these patients, they'll have deep dagger-shaped Q waves. I'll show you that ECG. And 2D echo will show you that there is septal hypertrophy, right? And how much should be that thickness? It should be more than 1.5 centimeters. Now, what is the role of TMT? What is the role of exercise studies? The exercise studies will tell you the risk of VT or VF. How? Remember, upon doing exercise, in a normal individual, the blood pressure increases. But in a case of patients with HOCM, if the blood pressure is not increasing, those patients are at increased risk of VT and VF. Blood pressure should increase. If the blood pressure does not increase, these patients are at increased risk of the arrhythmias. And medical management, first and foremost important advice is avoid exertion. Avoid exertion. And drug of choice will be beta blockers, right? And if beta blockers are contraindicated due to underlying respiratory disease, then you need to give non-dihydropyridine calcium channel blockers. And examples of non-dihydropyridine calcium channel blockers will be diltiazem and verapamil. And what is the surgical management that you need to do in these individuals is septal myomectomy. Septal myomectomy, or another important is alcohol septal ablation. Alcohol septal ablation. So this is about the entire story related to the HOCM, hypertrophic obstructive cardiac. And those individuals who are at increased risk of VT and VF, in them, you need to place ICD, that is implantable cardioverter defibrillator. So that was about the story related to HOCM, right? Then, next important is, yeah, you can see that. So whenever there is septal hypertrophy, the shape of the LV will be like banana-shaped LV. Okay. Whereas if it is the apical hypertrophy, you have what is called ace of spades appearance. And ECG, as I have said you will have dagger-shaped Q waves. And these dagger-shaped Q waves, they are mainly observed in V5 and as well as V6 and 2, 3 and AVF, right? That was about the ECG in HOCM. Next. Now, coming to the restrictive cardiomyopathy. Right? I will take exactly 1 to 1.5 minutes for restrictive cardiomyopathy. Now, restrictive cardiomyopathy is also the one which will be causing heart failure with preserved ejection fraction, where the ejection fraction will be more than 50%. Then what is the most common cause for restrictive cardiomyopathy? That will be amyloidosis, right? And that too, which type of amyloidosis? That is AL type of amyloidosis. And apart from that, radiation and myocardial fibrosis. And then we have some storage disorders that will be causing your restrictive cardiomyopathy, which is nothing but the Fabry's disease. What is Fabry's? It's a genetic disorder where you have enzymatic deficiency, that is alpha galactosidase A deficiency will be there. And the other infiltrative disorders that will be causing the restrictive cardiomyopathy will be hemochromatosis and then sarcoidosis. But remember, this hemochromatosis is also associated with the dilated cardiomyopathy. And the pathophysiology is diastolic dysfunction. And what will be the clinical features? They'll have both. Right heart failure features will be there and left heart failure features also will be there. But right heart failure features are more common than left heart. Why? Because right ventricle is thin-walled than compared to that of the left ventricle. And if there is any infiltrative disorder, right ventricle gets affected first because it is thin-walled. Okay. Then on examination in patients with the restrictive cardiomyopathy, what is very important is JVP, which is elevated. And these patients, they will have the Kussmaul sign. And these patients, they will have deep X and as well as Y wave. What does the ECG show? That will show you that there is low voltage complexes, similar to that of constrictive pericarditis. What does the 2D echo show? In case of amyloidosis, if it is the cause for restrictive cardiomyopathy, you have what is called as a speckled pattern. What is speckled pattern? You have white dotted appearance over the myocardium. I'll show you that. Then the investigation of choice to make out the etiology will be endomyocardial biopsy. Endomyocardial biopsy will tell you what exactly is the cause, right? What exactly is the cause of the restrictive cardiomyopathy. Then the medical management is similar to that of your heart failure, where you need to give the diuretics. diuretics, and then you need to give the beta blockers. Then ACE inhibitor, similar to that of your heart failure, like you need to give the treatment. Okay. So, and these patients on examination, they will have right atrial and left atrial dilatation. Because of right atrial and left atrial dilatation, they will have functional MR and functional TR. And whenever there is atrial dilatation, these patients, they are at risk of the atrial fibrillation. Once there is atrial fibrillation in the treatment, you need to add the anticoagulants. Right? You need to add anticoagulants. So this is in short about the restrictive cardiomyopathy. Right? Let me show you the images. So this is what is your low voltage complex, where the QRS complex is less than 10 mm in the chest leads and less than 5 mm in the limb leads. Right? And this is what is your speckled pattern that you will have in patients with the restrictive cardiomyopathy, where you have white dotted appearance. Okay. Then anticoagulation, yes. So that is about the story related to RCMP. Okay. Now, coming on to the next question. In which of the following cases does paradoxical splitting occur? Severe AS, RBBB, RV pacing, HOCM. Select the correct answer using the code given below. What do you mean by the word paradoxical splitting? Normally, if you take second heart sound, you have A2 and then followed by that P2. Paradoxical splitting means you will listen P2 first and then followed by that A2. That is what is called paradoxical splitting, right? So where all you will have paradoxical splitting is, you will have that in severe aortic stenosis. You will have P2 then followed by that A2. You will have that in right bundle branch block. I'm sorry, not in right bundle branch block. You will have that in case of the right ventricular pacing, where you will have P2 followed by that A2. And you will also have that in HOCM, where you will have P2 followed by that A2. Okay. So this is about what is called paradoxical splitting. And you need to know the important points about the second heart sound. The conditions where you will have wide split S2. Wide split S2. That means A2 and P. So wide split S2 is due to what? This is due to early A2 and delayed P2. Early A2 and delayed P2. This early A2, you will have that in VSD and as well as mitral regurgitation. Delayed P2, you will have that in case of pulmonary embolism. You will have that in patients with pulmonary hypertension. And that too, it should be like massive pulmonary embolism, right? Then you will have the delayed P2 in cases of the right bundle branch block, right? And you will also have this in case of left ventricular pacing. You will also have this in case of left ventricular ectopics. And one more condition, that is in ASD. So these are all the conditions where you will have delayed P2, resulting in wide split S2. So this was, and paradoxical splitting is that you will have P2 followed by that A2, and that you will have in severe aortic stenosis, right ventricular pacing, and as well as the hypertrophic obstructive cardiomyopathy. Right? Now, yes, as we have discussed. Yeah, coming on to the next question. Yes, please answer this. We have a patient with peripheral edema, has the following findings on examination. A soft systolic murmur at the lower left sternal border with raised JVP showing prominent CV wave. The murmur increases in intensity on deep inspiration. The most likely valvular abnormality is. The most likely valvular abnormality is VSD, MR, TR, mitral valve prolapse. Very good, Dr. Vicky. So the answer is the tricuspid regurgitation, right? Because what is the very important point which is telling you it is mitral tricuspid regurgitation? That is increase in the intensity of the murmur on inspiration. What is this particular sign? This is called as the de Carvalho's sign. This is called de Carvalho's sign. So all the right-sided murmurs, they increase on inspiration. And that is what is suggestive of TR. And not only that, in TR, if you take JVP, JVP is increased, right? And what are the abnormal waves in the JVP, in TR? So first and foremost, the X wave. You will have reversal of the X wave. X wave will not be there in case of TR, right? And what will be there? V wave will be there, but this particular V wave amplitude is increased. V wave amplitude is increased, and Y wave abnormality will be there, and that too, it is early Y descent, right? And that too, it is early Y descent. Okay, so this will be the JVP findings in patients with the tricuspid regurgitation, right? So that was about the story in TR. So in TR, what is a murmur? In TR, the murmur is the pansystolic murmur, right? So if you take the systolic murmurs, we classify them as the following, right? So between S1 and S2 is your systolic murmurs. You have early systolic murmur, right? You have mid systolic murmurs. Then you have late systolic murmurs. Then you have pansystolic murmurs. Where is it you have early systolic murmur? Early systolic murmur, you have that in case of acute MR and acute TR. Where is it you have mid systolic murmur? You have that in case of the aortic stenosis, pulmonary stenosis, and then HOCM. Where is it you have late systolic murmur? You have that in mitral valve prolapse syndrome and tricuspid valve prolapse syndrome. Where is that you have pansystolic murmur? You will have that in MR and as well as TR. You will have that in MR and as well as TR. Okay. So if you see the examples, this is the example of the pansystolic murmur. Sometimes they will give you images and they will ask you to identify the murmur, right? Now, where is that you will have this scenario, right? You have ejection click and with late systolic murmur. This you will have in patients with the mitral valve prolapse syndrome, right? Then you see this pattern, crescendo, decrescendo murmur. Crescendo, decrescendo murmur. Where will you have this? You will have this in AS, that is aortic stenosis. Okay, so that was about the story related to systolic murmurs. Then you take diastolic murmurs, the one which are heard between S2 and S1. So diastolic murmurs only we have two, early diastolic murmur and mid diastolic murmur. Where will you have early diastolic murmur? You will have that in AR and as well as PR. Where will you have mid diastolic murmur? You will listen that in MS and as well as TS. So these are the conditions where you will have the mid diastolic murmurs. Then lastly, you have continuous murmurs. Where will you have continuous murmurs? Patent ductus arteriosus. This is also called as the Gibson's murmur. You will have that in ruptured sinus of Valsalva. You will have that in case of the AV fistula, right? AV fistula, that is coronary AV fistula and as well as the peripheral AV fistula, right? And the other condition is in case of branched pulmonary stenosis. And you will also listen that over the mammary gland in pregnancy, and that we call it as the mammary souffle. That we call it as the mammary souffle, right? The other condition where you'll have this continuous murmur is, yeah, so this is about the conditions where you'll have the continuous murmur. So continuous murmur is that where you'll have, yes, even the venous hum as well. Even the venous hum as well. Okay, so these are the conditions where you'll have the continuous murmurs, right? So this is about the continuous murmur, which is heard at S1 and heard continues up to S2, again S1. Then all the right-sided murmurs, they increase on inspiration, and that we call it as, right? And that we call it as your D. Carvalho's sign. And all the left-sided murmurs, they increase on the expiration. They increase on the expiration. Okay, so that was about the story related to the cardiac murmurs, right? Then quick discussion on the JVP. So A wave represents what? That is the atrial contraction. C wave represents what? That is bulging of the cusp into the right atrium. X wave represents what? That is atrial relaxation. V wave represents what? That is venous filling into the right atrium. Y wave represents what? That is atrial emptying. Okay. Kussmaul sign is that where the JVP increases on inspiration is what is called Kussmaul sign. Okay. And how will be your JVP waves? This will be the JVP waves. Right. So you have A wave, C wave, X wave, and then V wave, and then Y wave. So this will be the JVP waves. Now let me discuss the abnormalities of these waves. So what are the conditions where the A wave is absent? That is in atrial fibrillation. Conditions where you have a giant A wave, that is in tricuspid stenosis, right atrial myxoma, right? Then in pulmonary stenosis and pulmonary hypertension. Then where is that you have Canon A wave? You will have that in patients with the complete heart block and as well as in case of junctional rhythm, right? Junctional rhythm. So these are the conditions where you will have A wave abnormalities. Then what are the conditions where the X wave is accentuated or increased? That is in patients with constrictive pericarditis, restrictive cardiomyopathy, and cardiac tamponade, right? And where is that you have reversal of the X wave? You will have that in tricuspid regurgitation. Okay, I will send you this PDF with annotations once the session is over on my Telegram channel, right? And what are the conditions where you have V wave abnormalities like V wave being increased? That is in tricuspid regurgitation. Then abnormalities related to the Y wave. Y wave, it is accentuated in patients with the constrictive pericarditis and restrictive cardiomyopathy. And conditions where the Y wave is absent, that is in cardiac tamponade, right? And conditions where there is slow Y descent, that is in tricuspid stenosis. And conditions where there is early Y descent, that is in tricuspid regurgitation. Okay, so that was about the story related to the JVP, right? Yes. Kussmaul sign, it is a clinical feature of. Kussmaul sign, it is a clinical feature of. Yes. Yeah. So just now we have discussed that is the constrictive pericarditis. Now you take this dilated cardiomyopathy. So I will just do a quick revision of the dilated cardiomyopathy. Just in 1.5 minutes, I will quickly revise the entire dilated cardiomyopathy. So dilated cardiomyopathy, it is a disorder where you have heart failure with reduced ejection fraction, where the ejection fraction is less than 40%. What is the most common drug toxin that will be causing dilated cardiomyopathy will be the alcohol. And what are the drugs that will be causing the dilated cardiomyopathy? That includes mainly the anti-neoplastic drugs, that is adriamycin. And we have a drug of abuse, that is cocaine, can cause the dilated cardiomyopathy. And we also have transducumab and as well as cyclophosphamide. And endocrine disorders that will be causing dilated cardiomyopathy will be diabetes mellitus and thyroid related disorders, both hypothyroidism and as well as hyperthyroidism. And nutritional deficiencies that will be causing dilated cardiomyopathy will be B1 deficiency and selenium deficiency. Neurological causes that will be causing dilated cardiomyopathy will be Friedreich's ataxia and Duchenne's muscular dystrophy and myotonic dystrophy. Infiltrative disorders that will be causing dilated cardiomyopathy will be hemochromatosis, right? And what will be the clinical features? Both left heart failure and right heart failure features, because ultimately all the patients with dilated cardiomyopathy, they will end up in the heart failure with reduced ejection fraction. And on examination, you have a characteristic pulse, that is dichrotic pulse. Okay, and you have additional heart sound S3 and S4, right? And 2D echo will show you that there is reduced ejection fraction, where the ejection fraction is less than 40%. Chest X-ray will show you that there is cardiomegaly. And how is that you will be able to make out that there is cardiomegaly on the chest X-ray? The cardiothoracic ratio will be more than 0.5. And how do you treat these patients? Similar to that of heart failure, but the drug of choice is ARNI, that is angiotensin receptor blocker, neprilysin inhibitor. And what is the example of this? That is valsartan is your angiotensin receptor blocker, and sacubitril, it is the neprilysin inhibitor. Okay, so that is what is nothing but your ARNI. Okay, and if the individual is refractory to medical management, then you need to place the individual on CRT, that is cardiac resynchronization therapy. But what is the important criteria which is required for placing on cardiac resynchronization therapy is wide QRS complex. The QRS complex should be wide, more than 120 milliseconds to place the patient on the cardiac resynchronization therapy. Then what do you understand by this word peripartum cardiomyopathy? Peripartum cardiomyopathy, it is a form of dilated cardiomyopathy that occurs in pregnancy. But during which month of pregnancy? Development of dilated cardiomyopathy during the last month of pregnancy or 6 months after the delivery, right? 6 months after the delivery. This is what is called peripartum cardiomyopathy, right? And what are the risk factors for peripartum cardiomyopathy? That is hypertension, that is preeclampsia. Then elderly age, right? Then multiparous females. Then multiparous females. Okay. Then what is the treatment for peripartum cardiomyopathy? It is similar to that of your heart failure, but ACE inhibitors should be avoided. And ACE inhibitors should be avoided because in heart failure, actually, we give ACE inhibitors. ACE inhibitors are contraindicated in pregnancy because that will affect the kidneys of the fetus, right? And the important molecule that you need to give is bromocriptine. Why is that you need to give bromocriptine in case of dilated cardiomyopathy? Is that because it is the breakdown fragments of prolactin that will be responsible for dilated cardiomyopathy. So you need to suppress the prolactin secretion. And for that, you need to give the bromocriptine. For that, you need to give bromocriptine. Okay, right. Next question. Yeah. A patient has a cardiac murmur that is best heard at the right second intercostal space. It increases with expiration. Also, the murmur reduces in intensity during sustained hand breath, but increases in intensity on inhalation of amyl nitrate. What is the likely lesion? What is the likely lesion? Yes. Very good. That is the hypertrophic obstructive cardiomyopathy. So basically, this is a dynamic auscultation. So in hypertrophic obstructive cardiomyopathy, the concept is very simple. Any condition where the LV volume increases, the obstruction decreases. When obstruction decreases, the intensity of the murmur decreases, right? And any condition which will decrease the LV volume, the obstruction increases. And what will happen to the intensity of the murmur? The intensity of the murmur increases. Okay, that is what is the story in case of the HOCM. And with amyl nitrate inhalation, what will happen with amyl nitrate inhalation? The LV volume decreases, obstruction increases, and murmur increases, right? And all the left-sided murmurs, what did we discuss? They increase on the expiration. Okay, so the answer here is the HOCM, right? That is hypertrophic obstructive cardiomyopathy. Then, yeah, please answer this. In the modified Valsalva maneuver, in modified Duke's criteria for infective endocarditis, which one of the following is not the major criteria? Which one of the following is not the major criteria? Anyone? Yeah. So which of the following is not the major criteria? Rod spots, right? Rod spots, these are minor criteria. Okay. Whereas new partial dehiscence of the prosthetic valve, positive blood culture, 2 out of 3, and new valvular regurgitation. So your option 1, 2, and 4, these are the major criteria. But what is the question asked? Which one of the following is not the major criteria? Which is nothing but rod spot, which is a minor criteria, right? Then next question, if you observe. Yeah. This just now we have discussed, right? The Osborne wave in the ECG show prolonged depolarization with distinctive convex elevation of the J point. These waves are associated with. These waves are associated with. Very good. So Osborne wave, which is also called J wave, present in hypothermia. But you have to remember that your Osborne waves, they are not just present. What exactly is your J wave? You see this. This is a J point, and this is the Osborne wave. Okay, where exactly at the J point you have a positive blip. That is what is called J wave, right? And what are the conditions? What are the non-hypothermic conditions? You have the presence of the Osborne wave. You will have Osborne wave even in case of the hypercalcemia. You will have Osborne wave even in case of Takotsubo cardiomyopathy. You will have Osborne wave even in case of acute myocardial ischemia. Even in acute myocardial ischemia, you have the presence of the Osborn wave. Okay, so that was about the story related to the Osborn wave completely. Next question. Yeah, so we have a 28-year-old male is suspected to be having hypertrophic obstructive cardiomyopathy. Which of the following statements are likely to be true on his examination? Maneuvers that decrease the preload will cause the murmur to intensify. Maneuvers that decrease the LV afterload will cause decrease in the intensity of the murmur. Murmurs of the HOCM becomes softer with passive leg raising. Murmurs of HOCM becomes louder with squatting. Okay, multiple times we have just discussed. Yeah, yes, Dr. Vicky. Hypothyroidism, they will have hypothermia, right? Whenever there is hypothermia, you can have Osborn wave, right? So the correct answer here is, see, maneuvers that will decrease the LV preload, there will be increase in the intensity of the murmur. That is correct statement. Okay, because the any maneuver which will decrease the preload, the obstruction increases. Then maneuvers which will decrease the LV afterload will cause decrease in the intensity of the murmur. That is a wrong statement. Any condition which is decreasing the afterload, the intensity of the murmur increases because more and more blood will move from LV to the aorta. And murmurs of HOCM become softer with passive leg raising. That is a correct statement because with passive leg raising, the venous return increases, preload increases, right? And LV volume increases, obstruction decreases, murmur decreases, right? And murmur becomes louder with squatting. That is a wrong statement because with squatting, what will happen? Venous return increases. When venous return increases, preload increases. When preload increases, LV volume increases. When LV volume increases, obstruction decreases in HOCM and the murmur becomes soft. Okay, so the answer here is the first option, 1 and 3. The answer here is 1 and 3. Okay, right. Yeah, which one of the following is a manifestation of the vascular phenomena in modified Duke's criteria? Which one of the following is the manifestation of the vascular phenomena in modified Duke's criteria? Yes. Good. Very good, Philadelphia. That is the Janeway lesions. Whereas the Osler's nodes, Roth spots, glomerulonephritis, these are all immunological manifestations. These are all the immunological manifestations, right? Whereas Janeway lesion, it is a vascular manifestation. And one more important vascular manifestation that you will have in infective endocarditis is mycotic aneurysms. Right, mycotic aneurysms. Okay, so yeah, so this is the splinter hemorrhage that you will have in patients with infective endocarditis, right? Then this is the digital infarct that you will have in patients with infective endocarditis because of the embolization of the vegetation, right? And this will be the Roth spots, which is nothing but the retinal hemorrhages, okay, which is nothing but immunological phenomena. It is not the vascular phenomena, okay. Then these are the Osler's nodes, which are present in the pulp of the finger. These are very tender, right? And Janeway lesions, which are present in the palm, and these are non-tender. These are non-tender, okay. So this is about the vascular phenomena and as well as the immunological phenomena, right? This is very, very important question. We have a 60-year-old diabetic female presenting with acute myocardial infarction. The ECG changes include ST segment elevation greater than 1 mm in the lead AVR, right? Greater than 1 mm in lead AVR. The likely localization of the thrombosis is in. The likely localization of the thrombosis is in. That is in the no. In AVR, if you are having ST segment elevation, please remember this is a very, very important point to tell you that the pathology is in the left main coronary artery or in the proximal left anterior descending artery. Pathology is in the left main coronary artery or in the proximal left anterior descending artery. Okay, I'll show you that. You see, this is what is your ST segment elevation in AVR. ST segment elevation in the AVR. Okay, so what exactly is this? This is STEMI, ST elevation MI, right? And in case of ST elevation MI, what is the first line treatment? That is aspirin. What are all the various drugs that we give as a loading doses in case of ST elevation MI? That is aspirin, clopidogrel, or you can also give ticagrelor, and as well as the atorvastatin, right? And anti-anginal. So either you will give morphine or the nitrates. The advantage of morphine or nitrates, both of them, they will decrease the preload, and you need to give oxygen, right? And in those places where the PC, actually, what is the best method of revascularization? The best method of revascularization is PCI. Okay, but in those places where the PCI facility is not available, then you need to do thrombolytic therapy. And door to needle time is how much? That is 30 minutes. And door to balloon time is nothing but your PCI, which is nothing but 90 minutes. Okay, and what are the indications for your revascularization with your PCI? That is STEMI, right? And in all the patients with chronic stable angina, where there is more than 70% stenosis, there also we do the PCI, right? And what we use is drug-eluting stents, that is sirolimus or everolimus eluting stents. Then next is you need to do CABG. What is the indication for CABG? The indication for CABG is severe left main coronary artery stenosis. Okay, severe left main coronary artery stenosis, right? Then presence of diabetes mellitus with triple vessel disease, we do CABG, right? Or two vessel disease with left ventricular dysfunction, we do CABG. And what are the grafts that we use in case of CABG? The grafts that we use is saphenous vein graft or left internal mammary artery. Saphenous vein grafts or left internal mammary artery. Okay, but between these two, which is more efficacious? Left internal mammary artery or left internal thoracic artery, that is more efficacious. The patency rate will be good in case of Lima than compared to that of the saphenous vein grafts. Okay, so this is about the treatment of the ST elevation MI. The best method of revascularization is PCA. Okay, and what are the various thrombolytic agents? Streptokinase, urokinase, altiplase, tenecteplase, and then one more, right? So we have streptokinase, urokinase, altiplase, tenecteplase, and retiplase. But out of all these, the maximum revascularization can be done by the tenecteplase. Maximum revascularization can be done by tenecteplase. All right. Then coming on to the next question. Which of the following are typical findings in pericardial effusion? Not with retiplase, tenecteplase. Tenecteplase is the one which will cause maximum revascularization. Okay. Yeah. Findings seen in, okay, massive pericardial effusion. Raised JVP, hypotension, oliguria, Waterhammer pulse. Yes, the correct answer is, so you'll have raised JVP, hypotension, and oliguria, but not Waterhammer pulse. Waterhammer pulse is characteristically seen in case of the aortic regurgitation, right? Now, I'll just quickly, within 1 minute, I will discuss the pericardial effusion, okay? Right. Now, if you take the normal pericardial fluid, how much is the normal pericardial fluid? That is around 20 to 30 ml. When do you call pericardial effusion? When the quantity of the fluid is more than 50 ml in the pericardial space, we call it as the pericardial effusion. And what is cardiac tamponade? It is not the quantity which is important here. It is abrupt accumulation of the fluid in the pericardial space will result in the cardiac tamponade. And in cardiac tamponade, what will be the important clinical manifestation is sudden onset dyspnea. What is the Bextroyard? Bextroyard, it is observed in the cardiac tamponade, where you will find that the patient will have the hypotension, the JVP will be elevated, and there will be muffled heart sounds, right? Muffled heart sounds. And what is the characteristic pulse in case of the cardiac tamponade? That is pulsus paradoxus, right? Pulsus paradoxus. And how will be the JVP in patients with cardiac tamponade? JVP will be elevated and Kussmaul sign will be absent in patients with the cardiac tamponade. right? And you will have absent Y wave. You will have absent Y wave, okay? And deep X wave, right? Deep X wave, right? That is what is your JVP findings in cardiac tamponade, right? Yeah, non-pulsatile JVP, right? Then ECG will show you there will be electrical alternance. Electrical alternance, where you have alternating amplitude of the QRS complexes. One QRS complex will be large and the other QRS complex will be small. Okay. Then, whereas only in pericardial effusion, if you observe, it is low voltage complexes. Right? What is the 2D echo will show you? There will be right ventricular diastolic collapse. Right ventricular diastolic collapse. Okay. And then the ventricle will be dancing within the fluid. Then what is the treatment of choice? Pericardiocentesis. And this pericardiocentesis, what is the approach? That is subxiphoid approach. That is subxiphoid approach. Okay. So this is about your story related to, right. So this is about the story related to the pericardial effusion and as well as the cardiac tamponade, right? Next. Yeah, this will be the ECG in massive pericardial effusion or in case of the cardiac tamponade, where you have alternating large and small complexes, right? Then, yeah, which of the following condition can produce third heart sound on auscultation? Okay, which of the following conditions cannot produce? Which of the following conditions cannot produce third heart sound? No. Please listen. Which of the following conditions cannot produce? Yes, so mitral stenosis. In mitral stenosis, you don't have the third heart sound, right? Where is it you listen physiological S3? In young age, you will have physiological S3. Pregnancy, you will have physiological S3, right? Athletes, you will have the physiological S3. And all the conditions which are causing left ventricular failure and right ventricular failure, you will have the third heart sound. And third heart sound is heard during which phase of the cardiac cycle? That is during first rapid filling of the cardiac cycle, you will listen the physiological S3, right? And next important point related to the S3 is that S3, it is heard at the apex. And it is a low-pitched sound. It is heard with the bell of the stethoscope. Okay. That is about the third heart sound. Next question. Yeah. And you take the fourth heart sound. Fourth heart sound, it is never heard physiologically. Okay. So there is no physiological S4. Okay. And it is also a low-pitched sound. And where is it heard? During which phase of the cardiac cycle it is being heard? That is in second rapid filling, you will have the fourth heart sound. Why is that due to? That is due to atrial contraction. That is due to strong atrial contraction, you will have fourth heart sound. And what are the conditions where you will have fourth heart sound? You will listen that in case of the HOCM. You will listen that in aortic stenosis and pulmonary stenosis. And you will also listen that in case of the myocardial ischemia. So these are all the conditions where you will have the fourth heart sound. And you take the additional sounds. The additional sounds, they are pericardial knock, opening snap, tumor plop, ejection click. Pericardial knock, you listen that in constrictive pericarditis. Opening snap, you listen that in mitral stenosis. Tumor plop, you listen that in case of left atrial myxoma. Ejection click, you listen that in AS and as well as PS, right? And you take during which phase of the cardiac cycle? Okay, so your pericardial knock, it is a diastolic sound. Opening snap, it is a diastolic sound. Tumor plop, it is a diastolic sound. Whereas ejection click, this is a systolic sound. Ejection click is a systolic sound. And pericardial knock, please remember, it is the high pitched sound, right? And your opening snap, this is also high pitched sound. Tumor plop, it is a low pitched sound. And ejection click, again, it is a high pitched sound. Again, it's a high pitched sound. Okay. So this is about your heart sounds, right? Next, last question, I think. Which of the following statements are true about the PR interval? Which of the following statements are true about the PR interval? Right, good. So the correct answer is 4. So it denotes atrial depolarization is a wrong statement. Atrial depolarization is represented by P wave. And what is a normal PR interval? 0.1 to 0.20 seconds. Okay. And the prolongation denotes that there is AV block, first degree, second degree, and third degree AV block. Short PR interval is observed in WPW syndrome. This already we have discussed. Now, I just wanted to discuss one important abnormal wave in the ECG. The abnormal important wave in the ECG is, that is the epsilon wave. That is the epsilon wave. Now, what are the important points related to this epsilon wave is that which is observed in case of the ARVD. What is ARVD? ARVD is nothing but the arrhythmogenic right ventricular dysplasia. And how does this epsilon wave appear? The epsilon wave, it is nothing but it is a positive blip, right? It is a positive blip at the J point in lead V1. That is what is your ARVD. That is what is your epsilon wave in ARVD. That is arrhythmogenic right ventricular dysplasia, right? And if you take the description of the epsilon wave, you will have a positive blip in V1, right? And followed by that, you also have T wave inversion. Along with the positive blip, there is T wave inversion. And if you take the QRS complex, how is the QRS complex? It is a wide QRS complex. It is a wide QRS complex. So that is what is the ECG change in the ARVD, arrhythmogenic right ventricular dysplasia. And what exactly happens in the ARVD is, in ARVD, you have the right ventricular myocardium that is replaced by the fibrofatty tissue. Right ventricular myocardium is replaced by the fibrofatty tissue. Okay. And what exactly is the pathogenesis? Accumulation of the fibrofatty tissue within the right ventricular myocardium. And this fibrofatty tissue which is accumulated within the right ventricular myocardium, it is arrhythmogenic. It is arrhythmogenic. And what is the type of inheritance that you will have in ARVD? It is the autosomal dominant type of inheritance. But you have an exception. You have an exception, that is Naxos disease, which is autosomal recessive type of inheritance. And what is that features that you will have in Naxos? In Naxos, you have the 3 important features. That is, you see that. These are the features of the Naxos, which is autosomal recessive. You have the presence of the woolly hair in Naxos disease, right? And you will have the abnormality within the skin. The abnormality within the skin will be palmoplantar keratoderma, right? Palmoplantar keratoderma. Okay, that is what you will observe in case of the ARVD. That is arrhythmogenic right ventricular. That is in Naxos disease. And in Naxos disease, right? In Naxos disease, what exactly is the problem is you have the gene abnormality, that is Naxos gene. So basically, the protein which is being defective in case of Naxos disease is desmoplakin. Desmoplakin is being defective. What will be the clinical features in ARVD? That is palpitations. Why palpitations? Because this right ventricular myocardium, which is having fibrofatty tissue, that is at increased risk of VT and VF, right? Then what do you think is the first line investigation? That is 2D echo, which will show you that right ventricular myocardium is thin walled. That will be thin walled. And investigation of choice is what? That is MRI of the chest. MRI of the chest is the investigation of choice, which will show you that the myocardium is replaced by the fibrofatty tissue. That is the investigation of choice. And what is the treatment? Because these patients, they are at increased risk of the arrhythmias. You need to give the beta blocker, that is sotalol is being effective here. Sotalol is the effective drug. But finally, what is the intervention that you need to do is ICD, implantable cardioverter defibrillator. So why is that, right? Why is that you need to place ICD? That is, these patients, they are at increased risk of VT and as well as VF. That is the reason why you need to place the individual on the ICD, that is implantable cardioverter defibrillator. Okay, right. So that is the story of your the ARVD, that is arrhythmogenic right ventricular dysplasia, right? So with this, we are done, right? Okay, right. So with this, we are done with the cardiology aspect, right? So what is that we will do? We will wind up the session, or we will take a break and start with the connective tissue disorders. Hmm? Yes, we will take a break and then start with the connective tissue disorders. Okay. Right. So we will we will take a break and then we will start with the connective tissue disorders. Okay. Because again, we have many other chapters to go with, right? So we will have a break. Yeah. So I'll have some khana. So, and then we'll start with the connective tissue disorders. So it is like 10:05 now. So you take a break for 20 minutes. 10:25 we will start. 10:25 we will start. Okay.
But the person who made the upma for the first. It's sad in a way.
All right. So welcome back. So now let us start with the connective tissue disorders, right? Yes. So I hope I am audible and visible to all of you. Yes. Just give me a quick reply. Right. Great. Yeah, Vasif, I'll be covering neuro and as well as the renal also. I'll be covering all the chapters because yesterday we were not able to finish the session. So that's why the topics are due. Otherwise, I would have started neurology today itself. So the next session, I'll do neuro, I'll do renal, I'll do pulmonology, I'll do, yeah, and even gastroenterology and hepatology also I'll do. So I'll finish all the topics, right? Yeah, yes, Dr. Philadelphia. I had a quick khana and then came back. Now, let us start with the connective tissue disorders. So, in the connective tissue disorders, the first topic for the discussion, what are all the topics that I'll be discussing in the connective tissue disorders? That is gout, pseudogout, sarcoidosis, scleroderma, SLE, vasculitis, rheumatoid arthritis, and then the ankylosing spondylitis. Then I will be also revising the Behçet's disease or the Behçet syndrome. Okay, so these are all the topics that I'll be discussing. Chalo, okay, we'll start. So, are you all guys ready now? Right? Chalo, take the first question. So, we have a 45-year-old male presents with sudden onset severe pain, redness, and swelling in his right big toe. He described the pain as the excruciating pain, making it difficult to walk or even touch the affected joint. On examination, the joint is warm and tender to palpation. The laboratory investigation revealed an elevated serum uric acid level. What is the most appropriate treatment that you'll be doing in this patient? First of all, what is the diagnosis? First of all, what is the diagnosis? Anyone? Very good, Vasif. So this is a diagnosis of gout or gouty arthritis. Chalo, okay, good. But yes, what is the answer now? What is the answer? क्या करेंगे हम? Hot pack, ice pack, aspirin, steroid injection. So please remember, in case of acute gouty arthritis, yeah, so it is the ice pack. Okay, so it is the ice pack application. Now, what is the advantage of the ice pack application? So, application of an ice pack to the affected joint, it will help in reducing the swelling and it will also reduce the inflammation. Right, and it will also reduce the inflammation. That is the advantage of the application of the ice pack. Okay. And what exactly is the drug of choice? The drug of choice will be the NSAIDs. What is that we give? That is COX-1 inhibitors. But can we give aspirin in case of gout? Yes. Can we give aspirin in case of gout? Aspirin दे सकते क्या? So we cannot give aspirin because aspirin, it will further precipitate the gout or gouty arthritis. So you should not give aspirin. That is very, very important. Okay. Then what is that NSAID that we give is indomethacin. Right. The NSAID that we will be giving is the indomethacin. Okay. So, but the problem with the indomethacin is it can cause certain allergies. Some individuals, they have hypersensitivity to these painkillers like indomethacin. There can be development of rash. So if there is any hypersensitivity reaction with the COX-1 inhibitors, then we give COX-2 inhibitors. But COX-2 inhibitors, they are not effective, right? Then compared to that of COX-1. So we don't give COX-2 inhibitors as a first line. We give COX-1 inhibitors as a first line. Okay. Then now, apart from these NSAIDs, what will be the next line management in case of acute attack of gouty arthritis? In acute attack of gouty arthritis, the other drugs that we give is colchicine. And if the patient is refractory to the colchicine, we also give the steroid supplementation as well. But we never give aspirin. Okay, aspirin is contraindicated in case of acute gout. Okay, right. Now, let me quickly discuss about the gout or gouty arthritis. So, what exactly is the problem in gout or gouty arthritis? There is increase in the production of the uric acid or decrease in the excretion of the uric acid. That is a problem in case of gout. What do you understand by the secondary gout? That is the increase in uric acid levels secondary to drugs, trauma, surgery, alcohol containing beverages. Now, what are the drugs which will increase the uric acid levels? The drugs which will increase the uric acid levels will be, right? What are the drugs which will increase the uric acid? That is isoniazid, then pyrazinamide, then the aspirin, then aspirin. Okay, so these are the drugs, and next is thiazide diuretics. Next is thiazide diuretics. So even this will cause the hyperuricemia. And the joint which is most commonly affected is the MTP. That is the metatarsophalangeal joint. Yeah, even anti-cancer drugs. That is anti-cancer drugs because they cause tumor lysis syndrome. And what are the risk factors? Non-modifiable risk factors are males, they are more commonly affected than females, then advanced age. What are the modifiable risk factors? That is diet, which is rich in meat, right? And soda and as well as fruit juices, which is rich in fructose content, and drugs like your thiazide group of diuretics. Obesity. Even obesity is also a modifiable risk factor. Okay. Then what is the important clinical feature that these individuals will have? That is severe pain within the first MTP. What is the investigation of choice? The investigation of choice will be arthrocentesis has to be done, right? That is from the first metatarsophalangeal joint, you need to do arthrocentesis. When you do an arthrocentesis, what is that you will observe? When you do an arthrocentesis, you will observe that negatively birefringent monosodium urate crystals. And these monosodium urate crystals, that will be needle-shaped crystals. That is what you will observe under the microscope. And it's an inflammatory pathology. So the ESR is elevated and as well as the C-reactive protein is also elevated in these patients. Okay. Then when you do an X-ray, in these patients with gout or gouty arthritis, what is the earliest manifestation? The earliest manifestation is the development of joint effusion, right? The development of the joint effusion. Okay. And you will have this rat bite lesions. Rat bite lesions that will be observed on the X-ray. And what is the name of these rat bite lesions? These rat bite lesions, they are called as the Martel sign. These rat bite lesions, they are called as the Martel sign. Okay. So this is about the X-ray in patients with the gout or gouty arthritis. Now, what did I tell you? That aspirin. You see, a 62-year-old woman presented to the hospital experiencing an acute gout attack. Her physician prescribes aspirin for another medical condition. Which of the following doses of aspirin would be appropriate considering her symptoms of acute gouty attack? Please remember, if the dose is more than 5 grams per day, right? If the dose of the aspirin, if it is more than 5 grams per day, then that will precipitate the attack of gout. That will precipitate the attack of gout. Okay. Next question. We have a 65-year-old male with known history of renal failure presented to the clinic with recurrent episodes of acute gout. He complains of severe pain, redness, swelling in his left ankle. Lab investigations revealed elevated uric acid levels. More than 5 grams. More than 5 grams. He has drug of choice. More than 5 grams per day is the one which will precipitate the attack. Right? Okay. So What is the most appropriate drug of choice for the long-term management of these patients with gout? Right. So if you take option A here, this is actually a tempting option. Option A is a tempting option here. And option A is not correct. Option A is not correct. Why? Okay. Why? Because actually in long-term management, we give xanthine oxidase inhibitors. Example of the xanthine oxidase inhibitors are allopurinol and as well as the febuxostat. Right? Allopurinol and febuxostat. Okay. But this patient is having renal failure. When the patient is having renal failure, can you give allopurinol? Can you give allopurinol in an individual who is having the renal failure? You cannot give. Right? So, yeah. So that is the reason why you need to give febuxostat in this patient. That is the reason why you need to give febuxostat in this patient. Right. Yeah. Okay. Right. We have a good question from the drug of choice. I'm very sorry. Right. Now, you take regarding the aspirin. I'm very sorry. I'm very, very sorry here. I'm very, very sorry. So you have low dose aspirin and you have the high dose aspirin. Right? Yes. Drug of choice, you are right, actually. Okay. Right. You have low dose aspirin and as well as the high dose aspirin. Right? During the acute episode, what is the question given? Which of the following doses of aspirin would be appropriate considering her symptoms of an acute attack? Appropriate. That means which you can give. If at all, if you want to give aspirin in the treatment of the gout, you need to give high dose aspirin. Low dose aspirin is the one which will precipitate the gout. Okay. Now, what is the mechanism of action? Whenever you give high dose aspirin, it will decrease the uric acid. How it will decrease the uric acid? By inhibiting the reabsorption of the uric acid, right? By inhibiting the reabsorption of uric acid in the kidney. Okay. So the correct answer here is dose more than 5 grams is most appropriate considering her symptoms of an acute attack. Okay. Right. Yes. Yes, your drug of choice. Is this clear for you now? Right. I hope this question is clear for everyone now. Okay. Now we will move on to the next question. Right. So we have a 60-year-old male presenting with stiffness and limited range of motions in his right knee. Right. On examination, no significant swelling or redness is observed in the affected knee, which is non-tender to palpation. The X-ray is shown below. Right, X-ray is shown below. The patient undergoes synovial fluid aspiration and microscopic examination of the synovial fluid. What type of crystals is most likely to be seen in this patient's synovial aspirate? Monosodium urate crystals, cysteine, calcium oxalate, calcium pyrophosphate. Very good. So the answer here is the calcium pyrophosphate crystals. The answer here is calcium pyrophosphate crystals. What exactly is the type of gout which is being mentioned here is the pseudo gout. Now, how is it you are able to identify this pseudo gout? You are able to identify this pseudo gout by what is called as chondrocalcinosis. Right, the X-ray of the chondrocalcinosis. The X-ray of the knee joint is showing chondrocalcinosis. What is chondrocalcinosis? Chondrocalcinosis is that where there is presence of calcium within the cartilage of the joints. That is called chondrocalcinosis. And this chondrocalcinosis, this will be the hallmark of the pseudo gout. And in pseudo gout, what is the joint which is commonly affected? the joint which is commonly affected in pseudo-gout will be the knee joint. Okay. And it is not only the knee joint, the other joints which are affected in the your pseudo-gout will be wrist. And you also have the involvement of the hips, and you also have the involvement of the shoulder. These are the joints which are affected in case of the pseudo-gout. Okay. Right. And the crystals that you will have is calcium pyrophosphate crystals. Then how is that you will treat the patients with the pseudo-gout? In the treatment in patients with the pseudo-gout is you need to give the steroids. You need to give the steroids. Okay. So these are the differences between the gout and pseudo-gout. So you have uric acid and calcium pyrophosphate crystals in pseudo-gout, needle-shaped crystals and rhomboid-shaped crystals, right? And it is the first MTP which is commonly affected in gout. It is a knee joint which is commonly affected in case of the pseudo-gout. Okay, done. So that is about the story related to the gout and as well as the pseudo-gout. And okay, one more question you see here. A 45-year-old male who works in a battery manufacturing factory presents to the emergency department with joint pain and swelling. He complains of pain in his wrist, knee, and ankle. On examination, there is evidence of joint effusion in multiple joints, including the wrist and knees. Laboratory investigation revealed elevated levels of the serum uric acid. What is the diagnosis of this patient? Right, very good, Shravanti Kodali. So the correct answer here is the Saturnine gout. Saturnine gout. What is Saturnine gout? Saturnine gout, it is a variant of gout where it is lead-induced gout. Lead-induced gout is nothing but the Saturnine gout. This Saturnine gout, which is lead-induced gout, it is due to chronic lead exposure. And this is commonly observed in individuals who are working in battery manufacturing industry. Okay, so lead exposure can disrupt the normal metabolism. Okay, lead exposure will disrupt the normal metabolism of the uric acid, and that will lead to increase in the uric acid levels within the blood. That will lead to increase in the uric acid levels within the blood. So that is what is the Saturnine gout. Okay, so that was about the story related to your gout or gouty arthritis, which is called, so gout we have discussed, pseudo-gout we have discussed, and then Saturnine gout we have discussed, right? Then the next topic will be the sarcoidosis, right? Now, you see this question related to the sarcoidosis. We have a 30-year-old female presenting with persistent dry cough, shortness of breath on exertion, and the skin nodules on the shin of her tibia. The chest X-ray revealed bilateral hilar lymphadenopathy and eggshell calcification, which is characteristic of sarcoidosis. To confirm the suspected diagnosis, a transbronchial biopsy is performed. What are the characteristic findings that are likely to be seen in patients with the blood examination? Right, what is that you will observe? Very good. So the ACE levels, they are increased. CD4 to CD8 ratio will be increased, and calcium levels are increased in patients with the sarcoidosis. Okay. So what will be the CD4 to CD8 ratio? CD4 to CD8 ratio in case of sarcoidosis, it is almost 1.5:1. Now, why the calcium levels are elevated in patients with sarcoidosis? That is because non-caseating granuloma, whichever is there in case of sarcoidosis, that will produce an enzyme called 1-alpha hydroxylase. And this 1-alpha hydroxylase is the one which is required for synthesis of active form of vitamin D. And that is the one which will be responsible for the hypercalcemia in patients with the sarcoidosis. Okay. Now, let me just do the quick revision of the entire sarcoidosis. So in sarcoidosis, what is the type of inflammation? It is non-caseating granulomatous inflammation. What is the other condition where you have the non-caseating granulomatous inflammation is in patients with ulcerative colitis also, you will have this non-caseating granuloma, right? Then, now you take the granuloma, what does it contain? It contains the macrophages. It contains the giant cells. Okay. And within these giant cells, you have the inclusion bodies. What are these inclusion bodies? S stands for Schaumann bodies. A stands for asteroid bodies. R stands for residual bodies. R stands for residual bodies. Okay, so this is what the granuloma contain. And so in sarcoidosis, what you have is non-caseating granuloma. Where is that you have caseating granuloma? Caseating granuloma is observed in case of the tuberculosis. And the other conditions where you'll have caseating granuloma is histoplasmosis and as well as the cryptococcus. Right, as well as cryptococcus. And the most common organ which is affected in sarcoidosis, that will be the lung. And what will be that lung in lung manifestation? Lung manifestation will be in the form of the interstitial lung disease, and there can be development of exudative type of the pleural effusion. Right? Then, so followed by the lung, right? Followed by the lung, the next important organ which will be affected is the skin. And what will be the skin manifestation? That is the erythema nodosum, right? Or lupus pernio, right? Lupus pernio. So this will be the skin manifestation, okay? And lymph node involvement, bilateral hilar lymphadenopathy will be there. And the heart involvement, it is rare. It is least common affected, heart. What will be that? Development of restrictive cardiomyopathy. And if at all, if there is death in patients with the sarcoidosis, what is the cause of death? The cause of death is the angioinvasive mycetoma and as well as the arrhythmias. These two are the causes of death in patients with the sarcoidosis. Okay. Now, the respiratory manifestations will be in the form of the respiratory failure. And the eye involvement will be in the form of uveitis. The eye involvement will be in the form of uveitis. And CNS involvement will be in the form of lymphocytic meningitis, and you have the involvement of the seventh nerve. And seventh nerve involvement, it is bilateral. Similar to that of your Guillain-Barré syndrome, here also you have bilateral seventh nerve involvement. Then what is the investigation of choice in sarcoidosis? That will be biopsy, which will show you the presence of non-caseating granuloma, right? And the gallium-67 scan has to be done, which will show you the panda sign and as well as the lambda sign. I'll show you both of these, okay? Lambda and as well as the panda sign. And what does the chest X-ray show? Chest X-ray will show you that there is bilateral hilar lymphadenopathy. And then you have this 1, 2, 3 sign, which is also called as the pawnbroker sign, which is called as pawnbroker sign. Okay, so this is what you'll observe in case of sarcoidosis. Let me show you all the images related to sarcoidosis. So this is what is your lupus pernio, where you have the purple color rash over the face, right? Then this is what is your erythema nodosum, which is observed over the lower limbs, where there is inflammation of the subcutaneous fat. And this is what is your bilateral hilar lymphadenopathy, which is characteristic manifestation in patients with the sarcoidosis. And this is what is called Gorland's triad or the pawnbroker sign, which is also called the 1, 2, 3 sign, where you have bilateral hilar lymphadenopathy. Along with bilateral hilar lymphadenopathy, you also have the right paratracheal involvement. Right paratracheal lymph node is also enlarged. That is what is nothing but your Garland's triad. And this is what is your lambda sign and as well as panda sign that is observed in gallium-67 scan. Okay, so in case of panda, it is the gallium-67 uptake in the lacrimal glands and as well as the parotid glands. Okay, whereas in case of lambda sign, it is in the hilar lymph nodes and as well as right paratracheal lymph nodes. Okay, so this is about, and what are the other investigations? When you take ACE levels, that is angiotensin converting enzyme levels, they are elevated. Then what is the drug of choice in these individuals? That will be steroids. Steroids, they are considered as the drug of choice. But with steroids, there is chances of Cushing's. Then what are the steroid sparing agents? The steroid sparing agents is you need to give hydroxychloroquine. And another steroid sparing agent is methotrexate. So in which conditions we use hydroxychloroquine or methotrexate is in patients with the rheumatoid arthritis. And another important steroid sparing agent is azathioprine. And in refractory cases, we give the infliximab. Yeah, methotrexate is also one of the another steroid sparing agent for sarcoidosis. Actually, that is a drug of choice for rheumatoid arthritis. Okay, right. So that was about the story related to the sarcoidosis. Answer this. A 35-year-old female presenting with complaints of swollen and as well as painful joints, along with low-grade fever, tender erythematous nodules on her shins. X-ray examination is shown below. Based on the clinical presentation and skin manifestation, which syndrome is most likely diagnosed? Behçet's, Lofgren syndrome, Retter's, erythema multiforme. Yes, right. Very good, VPR. So the answer here is this is not Retter's. This is not Retter's. This is the Lofgren's. Okay. So in Lofgren's, it is actually what? It's a variant of sarcoidosis. It's a variant of the sarcoidosis. Then what is that? You will have an additional feature in case of the Lofgren's is the joint pains. Painful and swollen joints. These are the additional things that you will have along with the manifestations of the sarcoidosis. That is what is called Lofgren's. Okay. And I'll show you the features of the Lofgren's. Yeah, you see this? You have everything. Lymphadenopathy will be there, granulomas will be there, erythema nodosum will be there, lupus pernio also will be there. But the additional manifestation is joint pain. Right? Then it becomes Lofgren. And if there is erythema nodosum, it's a good prognostic sign. If there is lupus pernio, that is a bad prognostic sign. Please remember that. That's a very important point. So what is Lofgren's? It's a variant of sarcoidosis, right? Next. Now, how will you rule out the other options? You take in case of Behçet's. What is the important features in the Behçet's? That is the presence of the oral ulcers. Recurrent oral after stomatitis. That is what you will observe in Behçet's. What is Retter's? You have a triad. That is arthritis, urethritis, then conjunctivitis. That is a triad in case of Retter's. Okay. Then you take erythema multiforme. Erythema multiforme is that you have target-like skin lesions. Right? You will have target-like skin lesions and mucous membrane involvement will be there. Okay, target-like skin lesions and mucous membrane involvement will be there in case of the erythema multiforme. So that was about the story related to sarcoidosis. The next topic is the scleroderma, right? So we have discussed two topics, gout and sarcoidosis. Now, you see the next question. A 31-year-old woman presents with fatigue and difficulty in swallowing for 8 weeks. She also complains of painful discoloration in her fingers and toes when exposed to the cold weather. She has smoked 1 pack of cigars daily for 3 years. She appears younger than her staged age. The physical examination showed smooth swollen fingers with small white calcification on the fingertips on both hands. Which of the following features will definitely be seen in this patient? Very good. So the entire clinical picture, it is suggestive of the scleroderma. What are the points suggestive of scleroderma? One is difficulty in swallowing. Why there is difficulty in swallowing? That is because of the esophageal dysmotility due to accumulation of the fibrous tissue within the esophagus or lower esophageal sphincter, right? Then you take these patients, they are having sclerodactyly. In the fingers, whatever they are having is the skin, it has become completely stiff. Okay. And what are the precipitating factors here? That is, he is a smoker also, which will cause vasoconstriction. And you also have calcification. So all these are the features suggestive of the scleroderma. So what these patients will definitely have is the sclerodactyly. They'll have sclerodactyly. Now, if you take this scleroderma, we have the two important forms of the scleroderma. So within just 2 minutes, I will finish the entire scleroderma, right? So scleroderma, which is also called systemic sclerosis, this is an autoimmune disorder where you have accumulation of the fibrous tissue. And there are certain drugs which will be causing scleroderma, like bleomycin. Can anyone tell me in which respiratory disorder we use bleomycin? In which respiratory disorder you will use bleomycin? Anyone? Bleomycin is the drug which is used in the treatment of which respiratory pathology? Used in the cases of recurrent pleural effusion. In recurrent pleural effusion, or in case of recurrent pneumothorax, we use this bleomycin to, so to obliterate the pleura, we use this bleomycin. What is pentagocin? Pentagocin, it is an analgesic, right? And then what is carbidopa? Carbidopa, it's a peripheral decarboxylase inhibitor. Okay. Then now we have two forms of scleroderma. One is localized and diffuse scleroderma. So localized scleroderma is that where you have the manifestations in case of localized scleroderma, you have a limited skin involvement. Okay. So rather than using this word localized, I will use the word it as limited scleroderma. So in case of limited scleroderma, you will have limited skin involvement. And that skin involvement in case of the limited scleroderma, it is in the fingers, then forearms, then face. That's all, right? Fingers, forearms, and face. And there will be a very slow progression of the disease. And visceral organ involvement will be there, but it is in the late. And these patients, they present with what is called crest. What is crest? That is calcinosis, where there will be distal calcinosis, subcutaneous calcification. R stands for Raynaud's phenomena. E stands for the esophageal dysmotility, right? S stands for the sclerodactyly. T stands for telangiectasia. This is what is your crest syndrome. Now coming to diffuse scleroderma. In case of diffuse scleroderma, what is the earliest manifestation? That will be Raynaud's phenomena. And in Raynaud's phenomena, what will be the color change of the fingers when exposed to the cold? So initially, the color will be white, that is pale in color. Later blue, that is due to cyanosis. Later it will be red, that is due to reflex vasodilatation. And when you observe the face of these individuals with scleroderma, the skin will be very tight and the mouth will be pinched mouth. They will not be able to open the mouth because of the accumulation of the fibrous tissue over the angle of the mouth. And what will be the GIT manifestation? The fibrous tissue will get accumulated within the lower esophageal sphincter, causing GERD. And fibrous tissue will get accumulated within the entire intestine, and absorption of the nutrients across the intestine does not occur, resulting in pneumatosis intestinalis. And lung manifestations will be in the form of ILD, and cardiac manifestations will be in the form of restrictive cardiomyopathy in case of scleroderma. So all these are observed where? These are observed in case of diffuse. Now, these patients, they are at increased risk of pulmonary hypertension. Why there is pulmonary hypertension? Because of ILD. So ILD will cause hypoxia, and hypoxia is the one which will cause pulmonary artery vasoconstriction, resulting in pulmonary hypertension. And in fact, pulmonary hypertension is a cause of death in patients with the scleroderma. What is the renal manifestation? That is scleroderma renal crisis, right? So why is this scleroderma renal crisis? That is due to renal artery stenosis. These patients will develop hypertension due to increase in the renin levels. Musculoskeletal involvement will be there in patients with the scleroderma, that is in the form of the arthritis, right? And antibodies in these individuals will be, in limited scleroderma, the antibody will be anti-centromere antibody, right? Whereas in diffuse scleroderma, where there is visceral organ involvement, you have anti-topoisomerase antibody, right? Or the anti-SCL70. That will be the antibody in case of the scleroderma, right? Then gadolinium enhanced MRI, that should be avoided in patients with the scleroderma because that will be causing the excessive fibrosis. So you should not do gadolinium enhanced MRI in patients with the scleroderma, right? That's very, very important because that can cause nephrogenic fibrosing dermopathy. Nephrogenic fibrosing dermopathy. Then what exactly is the drug of choice? Because it's an autoimmune disorder, you need to give steroids. You need to give steroids. So this finishes your scleroderma, right? In quick recap, both limited and as well as the localized scleroderma or diffuse scleroderma, okay? Yeah. So this will be the Raynaud's phenomena. White color due to peripheral vasoconstriction, right? Cyanosis, that is blue color. Then followed by that reflex vasodilatation. Gradually, the fingers will turn red in color. Gradually, the fingers will turn red in color, okay? And where exactly the problem starts with? The problem, it starts from the tip of the digits, where you have the ulceration over the digits. or pitting of the nails. So you will observe nail pitting, right? Then you see this is your pinched mouth. This is a characteristic feature in case of the scleroderma. Okay, so that was the story related to the scleroderma, right? Next question. Which of the following is a treatment of choice for managing hypertension in patients with features such as Raynaud's phenomena, skin thickening, dilated blood vessels presenting with progressive increase in blood pressure, reduced GFR? Yeah, that pinched mouth is nothing but your microstomia. Very good. So now, what is the cause of hypertension in these patients? So what is this clinical picture suggestive of? This clinical picture, it is suggestive of scleroderma. So how is that you are telling it as scleroderma? Because the patient is having Raynaud's phenomena, skin thickening, and dilated blood vessels presenting with a progressive increase in blood pressure. So in scleroderma, what is the cause of hypertension? That is scleroderma renal crisis. And that is due to renal artery stenosis, where there is activation of RAS. So in order to neutralize the RAS, what is the drug that you need to give? AC inhibitors has to be given. AC inhibitors has to be given. Okay. But in spite of giving AC inhibitors, if the blood pressure is further increasing, then the drugs that we can give is calcium channel blockers can be given. The drugs that can be given is calcium channel blockers can be given. Okay. And finally, when there is fibrosis of the kidney completely, then you need to do kidney transplantation. Then you need to do kidney transplantation. Okay. And these patients, I said you, the lung manifestations will be in the form of the ILD. Whenever these patients develop ILD, then you need to give mycophenolate mofetil. Right? Mycophenolate mofetil should be given. So this mycophenolate mofetil is the one which can reduce the severity of the dyspnea, and it will cause improvement in the pulmonary function tests of the individual. Right? And what is the cause of death we have discussed? The cause of death is the pulmonary hypertension. And whenever there is development of pulmonary hypertension, you need to give bosentan. What is bosentan? Yeah, very good VPR. Yeah, if the patient is like not responding to mycophenolate mofetil, when the patient is refractory to mycophenolate mofetil, then you need to give this important molecule that is nintedanib. Right? What exactly is your nintedanib? It's an inhibitor of multiple tyrosine kinase. It's an inhibitor of multiple tyrosine kinase. When the individual does not respond to this mycophenolate mofetil, then you need to give nintedanib. And if for pulmonary hypertension, you need to give bosentan. What is bosentan? Bosentan is the endothelin receptor antagonist. And we also have the other drugs for pulmonary hypertension, like phosphodiesterase 5 inhibitors like sildenafil and tadalafil. Right? Guanylate cyclase inhibitor, example, riociguat. Riociguat is the guanylate cyclase stimulant, not inhibitor. It is a stimulant. And endothelin receptor antagonist, bosentan as well as macitentan. Okay. And in case of refractory pulmonary hypertension, these patients will be requiring prostacyclin pathway agonist. Right? Prostacyclin pathway agonist. What are those prostacyclin pathway agonists? That includes epoprostenol, then we have treprostinil, and then the iloprost. Right? Treprostinil and then iloprost. Okay, so these are the drugs that you have to give in case of refractory pulmonary hypertension. And in spite of medical management, if the individual is not recovering, then what is that you need to do is myeloablation followed by autologous stem cell transplantation has to be done. Okay, so this is about the scleroderma treatment part. Yes, answer this. A female patient presents with malar rash, Raynaud's phenomena, bilateral proximal interphalangeal joint and metacarpophalangeal joint pain, and wrist proximal muscle weakness. Labs reveal ANA. Which of the following antibodies specifically associated with this condition? I'll be very great if you answer this question. Which is the common cause, both types of scleroderma in pulmonary? Yes. Mohammad Noor, what is your, I didn't understand your question, Mohammad Noor. Which is the commonest common cause, both types of diffuse scleroderma. In diffuse scleroderma, pulmonary hypertension is more common than compared to that of limited scleroderma. Right. We have only two students answered this. We have Sunil Acharya and as well as Priya Patel answering this question correctly. That is anti-U1 RNP. Can anyone tell me what is the diagnosis? Very good, Sunil Acharya. The diagnosis is MCTD. Diagnosis is the MCTD. Okay, that is multiple connective tissue disorders or mixed, not multiple, mixed connective tissue disorders. See, when we are using this word mixed, how many should be there? Minimum 2 connective tissue disorders should be there, right? So either it could be SLE, right? Or it could be systemic sclerosis, or it could be polymyositis or dermatomyositis, right? Or it could be rheumatoid arthritis. So in this, any 2 should be there to call it as the mixed connective tissue disease. Now, our patient is having malar rash, suggestive of SLE. Our patient is having Raynaud's phenomena, suggestive of systemic sclerosis. Our patient is having proximal interphalangeal joint stiffness, that is suggestive of rheumatoid arthritis, right? Along with that, ANA is there. Enough, right? So 3 are there. 3 connective tissue disorders are there. So in mixed connective tissue disease, what is the specific antibody? The specific antibody is the U1 RNP antibody. U1 anti-dsDNA, it is present only in SLE. Right? It will tell you about the severity of the SLE. But are you having only SLE features? No. Then anti-Rho antibody, that is present in Sjogren's and as well as photosensitivity in patients with the SLE. Photosensitivity in SLE is mainly because of your anti-Rho antibody. Anti-La antibody, it is observed in Sjogren's. Okay. So that is about the story. So the answer is U1 RNP, that is mixed connective tissue disease. Right? Next. Now, yes, this is a very important question. Let me see who will answer. 25-year-old female presents with diffuse disfigurement of the face. Upon examination, there are areas of scarring and thick skin without any history. The patient does not exhibit any other significant symptoms. What is the most likely diagnosis in this patient? Yes. We have only 2 students answering correctly. Okay, now 3 students. Aspirant, Mohammad Noor, Priya Patel, Bhuvan Raghu. The answer is localized scleroderma. It is not limited scleroderma. Why? Because where exactly pathology is confined, pathology or abnormality is just confined only to the face, right? Only to the face. So there is disfigurement of her face. On examination, there is scarring and thickening of the skin, and there is no injury. And 1 minute. And does not exhibit any other significant symptoms. That is suggestive of localized scleroderma. What exactly is this? Basically, morphia. This is nothing but the morphia. Okay. So morphia is localized scleroderma. Morphia is localized scleroderma. Whereas limited scleroderma is what? You have skin involvement in the fingers, forearms, and as well as face. Morphia, only one part. Yes, I hope it is clear for all of you. And in morphia, you don't have the crest. In limited scleroderma, you will have crest. In limited scleroderma, yes, this is a very tricky question. That's why I was asking, like, who will answer? That is what I was thinking. Right? And so diagnosis is mainly clinical. Diagnosis is mainly clinical. Okay, right. Now we'll move on to the next question. Yeah, so we are done with the scleroderma. So what are all the topics done? Gout is over, sarcoidosis is over, then scleroderma is over. Then next important topic is SLE. Okay, systemic lupus erythematosus. Right. Which of the following statements about specific antibodies in SLE is incorrect, which is the incorrect option. Arey wow, excellent. Right, good. Right. So the correct answer here is anti-lupus anticoagulant. Anti-lupus anticoagulant, it is associated with increased risk of nephritis in SLE. It is associated with increased risk of nephritis in SLE, right? Whereas anti-Smith antibody, it is highly specific. That is a correct statement. Anti-Ro antibody associated with photosensitivity, and that will also cause neonatal lupus, that is complete heart block in the fetus. That's also a correct statement. Anti-dsDNA, it will tell you about the disease activity and severity. That's also a correct statement. But anti-lupus anticoagulant, it will increase the risk of nephritis in case of SLE. Okay. And what are the other antibodies that in SLE? Antihistone antibody. What is the role of antihistone antibody? That is in case of drug-induced lupus. And the other antibodies that you have in SLE is the APLA. APLA, it is associated with recurrent abortions, and it is also associated with venous thrombosis. That is what you observe in APLA. There is recurrent thrombosis. And because of this anti-erythrocyte antibody, these patients will have anemia. And it's a Coombs positive hemolytic anemia. Right? Coombs positive hemolytic anemia. And you have antiplatelet antibody that will cause thrombocytopenia. Anti-neuronal antibody, this is associated with the CNS lupus. Okay, where the individual will have seizures. And next important is anti-ribosomal antibody that is associated with psychosis. And what is the treatment that you will give if there is psychosis? You need to give haloperidol. You need to give haloperidol. Okay, and then we were just now talking about U1RNP, that is mixed connective tissue diseases. Mixed connective tissue diseases. Okay, right. Now, to quickly discuss about the SLE, what is SLE? It is an autoimmune disease. Because it's an autoimmune disease, this is more common in females rather than males. And it is antibody mediated and antibody causing immune complex deposition within the organs. So it is a type 3 hypersensitivity reaction. And just now we have discussed all these antibodies. We have finished all these antibodies. What is that? Most sensitive will be anti-nuclear antibody, right? Most specific will be anti-Smith. The antibody which will assess the severity, that will be, anti-dsDNA. Drug-induced lupus, it is antihistone antibody. What is the most common drug? What is the most common drug that is associated with lupus? Most common drug that will be causing lupus. Anyone? Most common drug that will be causing lupus, not INH. It is procainamide. Procainamide is a drug which will be causing the lupus. Okay. And we have many other drugs. Okay. Your INH is there. Okay. Hydralazine is there, which is an antihypertensive. Right. And then your sulfa drugs. Okay. Sulfa drugs. Right. Then photosensitivity, I have discussed anti-Ro. Your anti-neuronal antibodies, CNS manifestations. Right. And then we have anti-ribosomal P, that is psychosis. Right. Then antibody for thrombus formation is APLA. Now the question comes, what will be the most common clinical manifestation? What will be the most common clinical manifestation in case of the SLE? Most common clinical manifestation in SLE. Most common clinical manifestation in SLE will be fatigue. Yeah, very good, Bhuvana Raghu. There will be also joint pains, that is arthralgia. Fatigue and arthralgia. And followed by this, followed by fatigue and arthralgia, the next important manifestations that they will have is hematological manifestations. And that hematological manifestations will be in the form of normocytic normochromic anemia, and cutaneous manifestations are there. What will be the cutaneous manifestations? The cutaneous manifestations include malar rash, discoid rash, and as well as the ulcers. And what is the drug of choice in these patients? In acute episodes, we give methylprednisolone. Okay, methylprednisolone. But there are certain scenarios where the steroids are not useful in SLE. Now, what are the conditions where the steroids are not useful? Liebman-Sachs endocarditis, where you need to do valvuloplasty. Okay. APLA syndrome, you need to give aspirin. Along with aspirin, you need to give the anticoagulants. Other anticoagulants. Photosensitivity, your steroids will not be useful. Hydroxychloroquine should be given. And if there is severe lupus nephritis, then you need to give cyclophosphamide. Steroids will not be useful. And lupus nephritis with end-stage renal disease, steroids will not be useful. Kidney transplantation should be done. Psychosis in SLE, you need to give haloperidol. Okay. Then exacerbation of SLE in pregnancy, you need to give hydroxychloroquine. Development of lupus cerebritis, you need to give dexamethasone. Right? So this is about the various scenarios in SLE where steroids are not useful and the respective management. And what are all the various diagnostic criteria for SLE? So this is a diagnostic criteria, right? So totally 11 criteria are there. So out of which 4 should be there. Okay. So what is that mnemonic? That is soap brain MD. What is this soap brain? Like it's a mnemonic, right? You wash your brain with soap, then you will get an MD seat. Okay. So S stands for serositis, that is pleuritis and pericarditis. O will be oral ulcers, arthritis. And please remember the type of arthritis that you will have is non-erosive arthritis. Photosensitivity, blood disorders. What will be that blood disorder? It will be pancytopenia because antibodies are formed against each and every cell. So thereby there will be pancytopenia. And what will be the renal involvement? Renal involvement will be in the form of lupus nephritis. And the characteristic lesions will be wire loop lesions. Okay. And you have totally 6 classes, class 1 to class 6. Okay. Out of which class 4 is diffuse lupus nephritis. AMA is most sensitive. Then immunological. Then neurological features in the form of seizures and psychosis. Malar rash and discoid rash. Okay. So this will be your soap brain MD. Right. So that was about the story related to the entire SLE. Now we'll do a few more questions on the SLE. Yeah. We have a 21-year-old female presented to the clinic with complaints of fatigue, weight loss, arthralgia, and erythematous rash over the cheeks, nose, sparing nasolabial folds. Which of the following statement is incorrect regarding the patient's likely diagnosis? Incorrect statement. Yes. What is the incorrect statement? Very good. So the answer here is D. Incorrect statement is D. Let me tell you why. Renal failure is the most common cause of death in patients with SLE. It's a correct statement. Infections become leading cause of death in SLE if is not active due to immunosuppressant use. That is also a correct statement. And female to male ratio in SLE is almost 9:1. And please remember, Klinefelter syndrome may exhibit less severe symptoms due to the presence of additional X chromosome is a wrong statement. The severity of the SLE is directly proportional to the number of X chromosomes. More is the number of X chromosome, more severe will be disease. And in Klinefelter syndrome, you have an additional X chromosome. So that is the reason why it is not less severe. Patients with Klinefelter syndrome, they will have more severe symptoms. they'll have more severe symptoms. Okay. Next question. Yeah, more X, more severe, right? Okay. So we have a 28-year-old female presents with joint pain and swelling involving multiple joints. She also complains of low-grade fever. On examination, there is tenderness and soft tissue swelling in the affected joints. Which of the following features is most likely associated with synovitis in SLE? Yeah, go through all the options and tell me. Symmetrical joint involvement, asymmetrical joint involvement, unilateral joint involvement, bilateral joint involvement. What do you think is the correct answer? Right. So, yes. Okay. So I was expecting at least one student to answer C, which is incorrect actually. So, actually, you will have non-erosive arthritis. You will have non-erosive arthritis. And you have two options with non-erosive arthritis. That is A and as well as C. But remember, the joints that will be affected, it is not unilateral. It is symmetrical joint involvement. And you have the involvement of small and as well as the large joints. And there is intermittent polyarthritis. Okay, so symmetrical joint involvement, small and large joint involvement, intermittent polyarthritis, and it is non-erosive arthritis. It is not monoarthritis. Okay, and it is not unilateral, and it is not asymmetrical involvement. It is symmetrical involvement. Okay, so that is about the SLE associated synovitis. Whereas you take in case of the where will you have the asymmetrical involvement is even in rheumatoid arthritis also it is bilaterally symmetrical involvement. In Sjogren syndrome, the most common extraglandular manifestation is arthritis. In Sjogren's, you have actually lacrimal gland and salivary gland involvement. But in Sjogren's, there can be extraglandular involvement in the form of arthritis. And in Sjogren's, it is either symmetrical or asymmetrical. Okay. Next. Yeah. So with that, we are done with the topic related to SLE. So we have finished totally 4 topics. Then we will take up the vasculitis. Vasculitis is one of the very, very important topic. Right. 70-year-old male presents to the clinic due to stiffness and pain in the shoulders and hips for the past few weeks. He feels fatigued, low-grade fever, and also complains of persisting throbbing right-sided headache and jaw pain. On physical examination, a nodular swelling along the temporal artery is noted. HP examination is given. What is the treatment of choice? Yeah. What is the diagnosis here? What is the diagnosis? Diagnosis is giant cell arthritis or temporal arthritis. Now, can anyone tell me what is that symptom that is stiffness? What is the stiffness and pain and shoulders and hip? What is that stiffness and pain in the shoulders and hips for the past few weeks? This is suggestive of what? Polymyalgia rheumatica. This is suggestive of polymyalgia rheumatica. Okay. Now, why is that? These patients are having throbbing right-sided headache. That is because of the inflamed temporal artery. That is because of inflamed temporal artery. Now, why is that there is jaw pain? Because temporal artery is the one which will also be supplying to the muscles of mastication. So once the temporal artery is inflamed, the muscles of mastication will have reduced blood supply and there will be jaw claudication. Okay. And temporal artery biopsy, what exactly this is showing? It's a granulomatous inflammation. It's a granulomatous inflammation. Okay. Now, can anyone tell me what is the most feared complication in giant cell arthritis? What is the most feared complication in giant cell arthritis or temporal arthritis? Very good. So it is loss of vision, blindness. So what could be the reason for the blindness? That is due to the involvement of the posterior ciliary branch of the ophthalmic artery. So due to the inflammation within the posterior ciliary branch of the ophthalmic artery, these patients, they can develop blindness. Okay. So this is about the temporal. And whenever you are taking the biopsy, right, you need to take a biopsy of almost around 2 centimeters. Why is that you need to take the biopsy of almost 2 centimeters? Because the inflammation, it is not a continuous inflammation. It's a segmental inflammation. That is the reason why you need to take a biopsy of a longer segment. Okay, to see that you will not miss the diagnosis. and the age of presentation is more than 50 years. Okay, so this is about your giant cell arthritis. Right. Now, coming on to the next question. So the question goes like this. We have a 10-year-old child. One second. We have a big ad. I don't know. Acha, the ad is not coming for you. I am getting the very longer ad. Yes. Okay. Right. So easy question, right? Chalo, take it. What is another name for 10-year-old child presents with red raised rash on the buttocks and as well as legs? The mother reports that the child has joint pains, abdominal pain, fresh blood in the stool. Yesterday, labs reveal elevated IgA levels. What is the likely diagnosis? So this is your Henon-Schollen's purpura. What is another name for Henon-Schollen's purpura? What is another name for Henon-Schollen's purpura? Another name for Henon-Schollen's purpura. Anyone? Yeah. Why VPR? This is Burgers, huh? It is IgA vasculitis, right? VPR, why did you say Burgers? Yeah, so it is IgA vasculitis. What is the investigation of choice? What is the investigation of choice in these individuals? The investigation of choice will be the skin biopsy. Right? What does the skin biopsy show? The skin biopsy will show you that there is presence of leukocytoclastic vasculitis. Leukocytoclastic vasculitis, where you have the presence of IgA. And drug of choice is what? Steroids. Drug of choice is steroids. Okay. And these patients with Henon-Schollen's purpura, the most common cause of vasculitis in children. Most common cause of vasculitis in children. What will be that? That will be your Henon-Schollen's purpura. And this Henon-Schollen's purpura, it is characterized by a tetrad. What is the tetrad? Hematuria, that is glomerulonephritis. Right? S stands for skin involvement, that is purpura over the lower limbs and as well as buttocks. P stands for pain within the joints and as well as the abdomen. Pain within the joints and abdomen. So that is about the Henon-Schollen's purpura. Right? Done. Then we will move on to the next. A 6-year-old child presents with sore throat, fever, skin rash. Oral examination showed erythematous enlarged tonsils. The skin rash is blanching, papillar rash that lacks confluence. Which of the following is the most likely diagnosis? Okay, so some of you are answering it as A and some of you are answering it as B. So what is the correct answer then? Is it A or is it B? Is it A or is it B? Right. So it is not Kawasaki. It is scarlet fever. It is scarlet fever. Okay. Why? I'll tell you. Right. The rash which has been described in the clinical scenario, it is a characteristic of the scarlet fever. Okay. And you take the skin rash. The skin rash most commonly associated with bacterial pharyngitis, that is sore throat. Rash plus pharyngitis. Rash plus pharyngitis. That too in children. That too in children. That is very much suggestive of the scarlet fever. Right? And what did we discuss it as? It is an erythematous rash. Right? And this rash is blanching and as well as papillar rash. Okay, blanching papillar rash. You know what is this called as? This is called as the sandpaper rash. Yeah, very good. So who's that? Yeah, Suresh. Nice. So it is described as sandpaper rash. What is that? You will get the feel of a sandpaper. You will get a feel of the sandpaper. What is the organism here? The organism is Streptococcus pyogenes. That too, group A Streptococcus pyogenes. What are the other features that you will have in these patients? That is the presence of the pastia lines. Presence of the pastia lines along the flexural areas. And you have a strawberry tongue also. And that too, what is the color of the strawberry? It is red strawberry tongue. It is red strawberry tongue. And you will have lymphadenopathy here. It is bilateral cervical lymphadenopathy. Whereas, okay, bilateral cervical lymphadenopathy. Whereas in case of Kawasaki, it is unilateral cervical lymphadenopathy. Then how is that you will treat these patients? The treatment is with ampicillin. Okay, beta-lactam group of drugs you should give. Ampicillin should be given, right? So now we will see the next question. Okay, answer this. A 3-year-old child is brought to the pediatric clinic with a high fever for the past 5 days. His parents noticed redness in the child's eyes, rash on the body. On examination, physician observed unilateral lymph node enlargement in the cervical region. The child tongue appears to have a distinct appearance. What is the most likely diagnosis? Right. So this is your Kawasaki. This is your Kawasaki. Okay. So Kawasaki, it is not associated with any pharyngitis. And they will have unilateral cervical lymph node enlargement. And another name for Kawasaki is what? That is mucocutaneous lymph node syndrome. And what is the common age of presentation of Kawasaki? The common age of presentation of Kawasaki, it is around 5 years, right? Then what are the additional features? Very important is they will have fever. Very important is they'll have fever. Along with fever, they will have the 5 important manifestations. They have 5 important manifestations. What is that 5 important manifestations? Just remember this mnemonic as CREAM. Okay, C stands for conjunctivitis, and that too, it is non-exudative conjunctivitis. Okay, and there will be rash, there will be edema, there will be adenopathy, that is lymphadenopathy, that too unilateral. And M stands for mucosal involvement. And out of these 5 manifestations, how many should be there? 4 out of 5 should be there. And what is the drug of choice? Drug of choice will be the IVIG, that is intravenous immunoglobulin should be given. Intravenous immunoglobulin infusion should be given. And what is the dose? That is 2 grams per kg. 2 grams per kg in the form of infusion should be given, right? So, and what is the most common vessel affected in Kawasaki? What is the most common vessel which is affected in Kawasaki? Anyone? The most common vessel that is affected in Kawasaki will be, right, that is coronary artery. Good. And what will be that coronary involvement? The coronary involvement will be in the form of coronary microaneurysms. That will be in the form of coronary microaneurysms. Okay. So that will be the complications that you will have. Now I'll just show you this table, which is very, very important. This is the difference between Kawasaki and as well as scarlet fever. So in Kawasaki, the fever should be there for at least 5 days or even more. And in scarlet, it is not required. Just 4 days is also fine, right? Mucocutaneous lymph node involvement, that is not seen in scarlet, but seen in Kawasaki. Strawberry tongue is there in both. Bulbar congestion, it is present only in case of Kawasaki. Periangual peeling and perianal peeling, that is observed only in Kawasaki, right? And scarlet rash, it is present in scarlet fever all over the body. Pastia lines, present only in scarlet fever. Lymphadenopathy, unilateral in Kawasaki, and it is bilateral in scarlet fever. Okay, so this is about the differences between the Kawasaki and as well as scarlet fever. And we describe it as the salmon-like or the erythematous rash, which is present all over the body, right? Then we'll move on to the next one. 22-year-old female from India presents with symptoms of arm claudication and significant difference in the blood pressure between her right and left arm. On further evaluation, she is found to have renal artery stenosis. Which of the following is the most likely diagnosis in this patient? Right. VPR, why did you say D? Why did you say D? That too in a 22-year-old female. Do you have a coarctation in a 22-year-old female? So the better answer should be your Takayasu. The better answer should be your Takayasu, right? Why? Because it's a first important, there is arm claudication, which is a characteristic feature in case of Takayasu arthritis, right? And the next important is differential blood pressure. Why you have differential blood pressure in Takayasu? Why? Because in case of Takayasu, the most common vessel that will be affected is left subclavian artery. Left subclavian artery is inflamed, so thereby the blood pressure or the pulse in the left subclavian artery, coarctation, no difference. It can be there. Difference can be there if it is like if the coarctation is present proximal to the left subclavian artery. But how is that you will rule out? How is that you will rule out the coarctation of the aorta in this is coarctation is a congenital heart disease. Okay, it's a congenital heart disease. Usually, it will be children. Usually, it will be children, right? And your drug of choice, it need not be like that. If the coarctation is present distal to the left subclavian artery, then you have difference in the blood pressure between upper limb and lower limb. Okay, where lower limb blood pressures will be less. Whereas if the coarctation is present proximal to the left subclavian artery, then you have difference in the blood pressure between right upper limb and as well as left upper limb. Okay, so it can be either. It need not be only difference in the lower limbs. But here the answer is what? Takayasu arthritis. Now to quickly discuss about Takayasu arthritis, the Takayasu arthritis, it is also known as pulseless disease because you will not be able to feel the pulse. And what is the inflammation in Takayasu? The inflammation that you will have in Takayasu is the granulomatous inflammation, right? You'll have granulomatous inflammation, okay? And it is both large vessel and it is mainly the large vessel vasculitis. And what is the drug of choice? Okay, what is the investigation of choice? What is the investigation of choice? Yeah, Akshay, 1 second, Akshay, I'll come to your question. The investigation of choice is MRI of the aorta, right? MRI of the aorta, okay? Then that is the investigation of choice. MR angiography. MR angiography. Now, Akshay is asking if there is bilateral renal artery stenosis, then what is a drug that you can give? That is calcium channel blockers can be given. You cannot give the ACE inhibitors, calcium channel blockers are given. And if there is bilateral renal artery stenosis with recurrent pulmonary edema, then these patients, they have to undergo PTRA, that is percutaneous transluminal renal angioplasty they have to undergo. Okay, so this is about the story related to Takayasu. And in Takayasu, what is the drug of choice? In Takayasu, the drug of choice will be steroid. In Takayasu, the drug of choice will be the steroids. Okay, so that finishes the story related to your Takayasu arthritis, right? Then yeah, another important vasculitis is polyarthritis nodosa. Polyarthritis nodosa, what type of vasculitis is it? It's a medium vessel vasculitis. And the most common vessel which is affected in polyarthritis nodosa is renal vessel. But in polyarthritis nodosa, you don't have glomerulonephritis. You don't have glomerulonephritis. And the vessel never affected in case of polyarthritis nodosa is pulmonary artery. And polyarthritis nodosa, it is most commonly associated with hepatitis B infection. They will have HBsAg being positive. And what type of inflammation? You will have the fibrinoid necrosis in case of the polyarthritis nodosa. Fibrinoid necrosis. And ultimately, what is the drug of choice again here in polyarthritis nodosa? That is, the steroids have to be supplemented. Okay, right. Next question. A 30-year-old female presents with recurrent episodes of epistaxis, sinusitis, and nasal ulcers. She also complains of hematuria and has lung lesions in the form of multiple cavities on chest imaging. Laboratory tests reveal the presence of C-ANCA antibody. Which of the following is the most likely diagnosis in this patient? Great. So now in case of Wegener's, you have a triad. upper respiratory tract involvement, lower respiratory tract involvement, and you have the involvement of the kidney. The upper respiratory tract involvement, what are the features here? Epistaxis, sinusitis, and as well as the nasal ulcers. And what is the characteristic description of the nose in patients with the Wegener's? The characteristic description of the nose in Wegener's, it is a saddle-shaped nose. Right? It is the saddle-shaped nose. Okay? Right? Why? Because you have the perforation of the nasal bridge. Because of the perforation of the nasal bridge, you have the saddle-shaped nose. Okay? Then how will be the gums in these individuals? They have strawberry gums. They have the strawberry gums, right? And in patients with the Wegener's granulomatosis, what is the investigation of choice? Investigation of choice will be the C-ANCA. C-ANCA is the investigation of choice. And C-ANCA is what? It's an antibody. What is the antigen? The C-ANCA, it is formed against the proteinase 3. C-ANCA, it is formed against the proteinase 3. And what is the drug of choice for the Wegener's? That is the steroids. Okay. And only with steroids, if the patient is not having an adequate response, then you can add cyclophosphamide or rituximab can be given in refractory cases. Rituximab can be given in refractory cases. Okay. So this is about the story related to the Wegener's granulomatosis. Okay. Then you take the microscopic polyangiitis. In microscopic polyangiitis, what is that you will have? You have the P-ANCA. You have the P-ANCA in case of the microscopic polyangiitis. And polyarthritis nodosa, just now we have discussed. What did I discuss? In polyarthritis nodosa, lung involvement will never be there. So that is the reason why your polyarthritis nodosa is ruled out. And in Church-Strauss syndrome, what is the characteristic manifestation in Church-Strauss syndrome? Presence of asthma. And eosinophil levels should be elevated. Okay, so that will rule out your Church-Strauss syndrome, right? So that is about the story related to the Wegener's. Then, coming on to the next question. A 30-year-old male patient presents with recurrent painful oral aphthous ulcers, scrotal ulcers, hypophaeon in the eye. Upon further evaluation, the patient is found to have HLA-B5 being positive. Which of the following is the most likely diagnosis? Very good. So the answer here is the Behçet's. So what is that which will tell you it is Behçet's is the HLA-B5 positivity that is very much suggestive of Behçet's. And in which country the Behçet's is very common? Behçet's is very common in Turkey. And what is another name for Behçet's? The another name for Behçet's is oro-oculogenital syndrome. Oro-oculogenital syndrome is what is called as the Behçet's. Yeah, it is also called as the Silk Route disease or the Silk Road disease, right? And what will be the common clinical manifestation? That is recurrent painful aphthous ulceration. Recurrent painful aphthous ulceration. That will be oro, right? Then coming to the genital, that will be in females, you have the ulcers over the vulva, right? And in males, there will be scrotal ulcers. There will be scrotal ulcers. And ocular involvement will be in the form of the anterior uveitis and as well as the posterior uveitis. That is what you will observe as a clinical manifestation. Then what is the workup that you will be doing is the Pathergy test. That will be positive. Okay. And the arteries which are commonly involved are pulmonary artery, and because of which these patients can have the pulmonary hypertension and there can be hemorrhage, and brain blood vessels also affected. And what is the treatment? You need to give topical steroids, that is for oral ulcers. And if there is systemic involvement, you need to give IV methylprednisolone and as well as azathioprine. So this is about the story related to the Behçet's. Okay. Then you take the other options. What is this Crohn's disease? It's an inflammatory bowel disease, right? And here you have mainly the involvement of the GAT, gastrointestinal tract. Okay. And in Crohn's, you will have oral ulcers, but presence of the scrotal ulcers, hypophaeon, that is not the feature of your Crohn's. Okay. And herpes simplex virus infection. In herpes simplex virus infection, you have the ulcers, right? You have ulcers, but the ulceration over the scrotum, it is not consistent in case of herpes simplex virus infection. And in SLE, what is that? You will have malar rash and as well as discoid rash, right? And oral ulcers can be there, but the having scrotal ulcer, it is not typical for the SLE. Next question. Yeah. Now, if you observe this, 52-year-old male patient presents with to the clinic with complaints of joint pain, cough, progressive fatigue over the past few weeks. On examination, you note purpura and petechiae on the patient's lower extremities. Laboratory investigation showed elevated creatinine levels and P ANCA is being positive. Urine analysis revealed proteinuria and hematuria. What is the most likely diagnosis? What is the most likely diagnosis in this patient? No, this is not Wegener's. In Wegener's, you will have C ANCA, right? Yeah. So, no, this is not PAN. This is not PAN. Yeah. So, this is microscopic polyangiitis. Microscopic polyangiitis, it is a small vessel vasculitis. Right? This is a small vessel vasculitis. Okay. And microscopic polyangiitis is the disorder where you don't have hepatitis B involvement. Where you don't have hepatitis B involvement and you have the P ANCA being positive. You have the P ANCA being positive. Okay. Right. That is what is your MPA, microscopic polyangiitis. Right. And what are the various manifestations in microscopic polyangiitis? These patients, they have mononeuritis multiplex. Mononeuritis multiplex. Gastrointestinal tract involvement will be there. And even there can be cutaneous involvement also in case of microscopic polyangiitis. You can see cutaneous involvement, purpura and as well as the petechiae, right? And mononeuritis multiplex, okay, you don't have that mononeuritis multiplex feature, right? Then how will you rule out the other options? You take polyarteritis nodosa. Polyarteritis nodosa, it is a medium vessel vasculitis and it is usually associated with the hepatitis B, right? And in this question, there is no mention of the hepatitis B at all. Okay, so that is the reason why polyarteritis nodosa is ruled out. And in in Wegener's, it is a C ANCA that will be positive. And how is that you will rule out the Henon-Schwallen's purpura? Henon-Schwallen's purpura usually occurs in children. And the characteristic manifestations will be palpable purpura, joint pain, abdominal pain, and renal involvement. Okay, 52-year-old feature, you don't have that in case of the Henon-Schwallen's purpura. So Henon-Schwallen's purpura, it is seen in children and as well as young adults. Children and young adults. Now you take this P ANCA. P ANCA is what? It's an antibody, right? Now the P ANCA, it's an antibody. It is formed against which particular antigen? It is formed against which particular antigen? What is the antigen here? The antigen will be MPO. The antigen will be MPO. That is myeloperoxidase. That is myeloperoxidase. Okay. Now, this P ANCA, it is positive in microscopic polyangiitis. It is positive in case of the Church-Strauss syndrome. It is also positive in the inflammatory bowel diseases. It is also positive in inflammatory bowel diseases. Okay, so that is about the story related to your P ANCA. Then we also have what is called atypical ANCA. What is atypical ANCA? That is the antibody which is formed against the protein 3 and as well as myeloperoxidase. Where do you get that? In some cases of inflammatory bowel diseases, you will have the atypical ANCA. Okay, so that was the story related to vasculitis. Done? Then. Yeah. Next question. Next topic, rheumatoid arthritis. We have only two topics. Rheumatoid arthritis, ankylosing spondylitis. Your connective tissue disorders are done. Yes. Which pair mentioning the deformity of the name and deformity involved is incorrect? Incorrect. So the deformities that you will have in rheumatoid arthritis is swan neck, Botany's deformity, mallet finger deformity. It is not the rheumatoid arthritis at all, and Z-line deformity will be there. Right. So, yeah. So whoever has answered B, whoever has answered B, that's the correct. I mean, that is the. It is not matching. In case of Botany's deformity, It is exactly opposite to that of swan neck deformity. What is that you will have? You will have the flexion in the PIP, right? And you have extension in the DIP. Okay. Swan neck deformity, that is matched. Mallet finger deformity, that is matched. But mallet finger deformity is not the feature of rheumatoid arthritis. Mallet finger deformity is observed in trauma. It is observed in trauma. And Z-line deformity is the one which is observed in case of the rheumatoid arthritis. So to quickly show you these deformities, yeah, so this will be your swan neck. This will be your Bottomley's deformity. And this will be the Z-line deformity. And this will be the mallet finger deformity. Okay. So, and this is your ulnar deviation. Ulnar deviation also will be observed in case of the rheumatoid arthritis. And rheumatoid arthritis, you also have the involvement of cervical spine. And what will be that cervical spine involvement? That is atlantoaxial dislocation. And because of this atlantoaxial dislocation, you know what will be the presentation of these patients? They will have spastic quadriparesis. They'll have spastic quadriparesis. Okay, that will be the atlantoaxial joint involvement. Okay, there is spine involvement, cervical spine. And actually, in rheumatoid arthritis, the most common joints which will be affected is the small joints. And the small joint involvement will be symmetrical. And what will be that small joint involvement? That is MCP, PIP, and as well as MTP. Right? DIP involvement will not be there. DIP involvement is a feature of osteoarthritis and psoriatic arthritis. Right? So that is about the story related to the joint involvement. Yeah. Which of the following statements about rheumatoid nodules is incorrect statement? Please answer. Right, very good. So we have the correct answer coming from Sajan. That is, your rheumatoid nodules, they are non-tender. They are non-tender. Okay. And almost 40% of patients with rheumatoid arthritis, they have the extra-articular manifestations. And you know what is the most common extra-articular manifestation? That will be rheumatoid nodule. Rheumatoid nodule is the most common extra-articular manifestations. And lung involvement will be in the form of rheumatoid nodules. Okay. And there will be also exudative type of pleural effusion with low pleural fluid sugar. And rheumatoid nodules will compress the peripheral nerves, causing mononeuritis multiplex. There can be development of carpal tunnel syndrome, and there can be also tarsal tunnel syndrome. And in carpal tunnel syndrome, the median nerve is compressed, and in tarsal tunnel syndrome, it is a tibial nerve that is compressed. It is a tibial nerve that is being compressed. Okay. And where exactly you will see these rheumatoid nodules? That is over the extensor aspect of the forearm. And these are non-tender. Right? These are non-tender. Okay. And this will be rheumatoid nodules within the lung. This will be rheumatoid nodules in the lung. And they will be having pleural effusion. And the type of pleural effusion will be exudative type of pleural effusion. Right? Exudative type of pleural effusion. And you also have involvement of the eye in patients with rheumatoid arthritis. What will be that? That is episcleritis. And not only that, these patients with the rheumatoid arthritis will also develop Sjogren syndrome. They will be also Sjogren syndrome. And I was discussing about the nerve compression. That is tarsal tunnel syndrome, where you have the involved compression of the tibial nerve. Carpal tunnel syndrome, where you have the compression of the median nerve. All right. Then, what will be the cardiovascular involvement in patients with the rheumatoid arthritis? That will be in the form of the cardiomyopathy. Okay, that will be in the form of cardiomyopathy. Okay, and there will be also coronary artery disease, and there can be also mitral regurgitation, and there can be also development of pericardial effusion. And what is the cause of death in patients with rheumatoid arthritis? The cause of death in patients with rheumatoid arthritis, it is due to coronary artery disease causing myocardial infarction. Causing myocardial infarction. Yeah, so there will be, yeah, scleritis, episcleritis, right? So this will be the cardiovascular system manifestation in patients with the rheumatoid arthritis. Done. So these are all the extra-articular manifestations in rheumatoid arthritis. Okay. Yeah. Please answer this question. 55-year-old male coal worker. If this word is given itself, then you should answer the question. Coal worker, and along with that, multiple joint pains, that too stiffness within the hands. What is the answer? Right? Very good. So that is Kaplan syndrome. So what is Kaplan syndrome? Kaplan syndrome is rheumatoid arthritis plus coal workers pneumoconiosis, right? And whenever you do a chest X-ray in these individuals, you have the presence of necrobiotic nodules. You have the presence of necrobiotic nodules. Okay, that is what is your Kaplan syndrome. What is Goodpasture syndrome? Here you have the involvement of the lung, that is hemoptysis, and you have the involvement of the kidney, that is the hematuria. Okay, and this is also an autoimmune disease where the antibodies, they are formed against alpha-3 chain of type 4 collagen in case of Goodpastures. Cushing syndrome is a disorder where you have increase in glucocorticoids. And Guillain-Barré syndrome is that where you have acute flaccid paralysis. And that too, it is ascending type of paralysis. Okay, so the correct answer here is what? That is the Kaplan syndrome, right? And in case of Kaplan's, this is how it will be. These are all the necrobiotic nodules. These are all necrobiotic nodules, right? So overall, in rheumatoid arthritis, multiple system involvement will be there. Then what is the investigation of choice? Investigation of choice is not RA factor. Investigation of choice is anti-CCP. Anticyclic citrullinated polypeptide. Why? Because RA factor, it is non-specific. It is present in multiple conditions apart from the rheumatoid arthritis. Okay. Now, you see a question on the treatment part. A 45-year-old woman has been experiencing joint pain, stiffness, and swelling in her hands and feet for several months. She finds it challenging to perform her daily activities. Her rheumatologist suspects an autoimmune disorder and prescribes medication that inhibits enzyme dihydroorotate dehydrogenase. What drug this is? Very good. Excellent. No. Bhuwana, it is not methotrexate. Methotrexate is what? It's a folate antagonist. It's a folate antagonist. So what is that drug which is dihydroorotate dehydrogenase? That is leflunomide. Leflunomide, it is a DMARD which is a dihydroorotate dehydrogenase. Okay, right. So by inhibiting this enzyme, what the leflunomide will do? Leflunomide will decrease T cell and as well as B cell proliferation. And by inhibiting T cell and B cell proliferation, it exhibits immunosuppressive effect. Immunosuppressive effect. So we have two types of DMARDs now. What is that? One is your non-biological DMARDs, which is nothing but your methotrexate, sulfasalazine, leflunomide, and hydroxychloroquine. And your biological DMARDs. What will be that biological DMARDs? That is anti-TNF alpha inhibitors, right? And as well as your rituximab. These are the DMARDs. And whenever you're giving DMARDs, what exactly is the drug of choice? The drug of choice will be methotrexate. Okay. And with methotrexate itself, if the patient is not responding, then we give triple therapy, hydroxychloroquine and as well as the sulfasalazine. Hydroxychloroquine and sulfasalazine. And with this is called triple therapy. And with this triple therapy, if the patient is not responding, then we start the biological DMARDs. Then we start the biological DMARDs. Okay. So this is about the story related to the treatment of the rheumatoid arthritis, right? Next. In pregnancy, can we give methotrexate? We cannot give methotrexate. We cannot give methotrexate in pregnancy. Why? Because it's a folate antagonist, right? And we require the folic acid during pregnancy. So methotrexate should be avoided in the pregnancy, right? Next. Yeah, so yes, whenever you are giving methotrexate, how is that you should give? Methotrexate, you should give once a week, right? You should give once a week, and remaining 6 days, you should give folic acid or folinic acid. Okay, because it's a folate antagonist, right? And what is the adverse effect associated with methotrexate? This can cause bone marrow suppression, causing pancytopenia. That is the adverse effect associated with the methotrexate. Okay, next question. A 50-year-old man with rheumatoid arthritis is started on methotrexate, but shows limited response despite several weeks of treatment. Leflunomide is added, but the patient again fails to respond after several weeks. Which of the following medication is likely to be prescribed next? Try the same regimen: adalimumab, hydroxychloroquine, and sulfasalazine. What is that you want to add? Right. So, yes, please remember here, you should be very tricky here. If you are giving methotrexate, hydroxychloroquine, and sulfasalazine, if there is no response, okay, then you need to start biologicals. But leflunomide is also more potent drug. When the patient is taking methotrexate and leflunomide, and if there is no response, then you need to start biologicals. Okay, so there is no question of adding, right? There is no question of adding sulfasalazine or hydroxychloroquine to this leflunomide regimen. Okay, when leflunomide is already there, no response, then you need to start biologicals. So what is the answer here? The answer is the adalimumab. What is adalimumab? Adalimumab, it is anti-TNF alpha. Adalimumab, it is anti-TNF alpha. So what this adalimumab will do? It will reduce the inflammation and it will slow the progression of the disease, right? And this adalimumab, it is not just prescribed only in the treatment of rheumatoid arthritis. There are many other autoimmune diseases where we prescribe this adalimumab. It is also prescribed in case of psoriatic arthritis. It is also prescribed in ankylosing spondylitis. It is also prescribed in Crohn's disease. It is also prescribed in ulcerative colitis. And it is also prescribed in case of the plaque psoriasis. These are all the conditions where you have the prescription of this adalimumab. Okay, so that is about the story related to. So you see the stepwise treatment. Step 1, methotrexate. Okay, then combination therapy. Methotrexate, leflunomide, no response, biologicals. Methotrexate, sulfasalazine, hydroxychloroquine, no response, biologicals. Okay, so this is very, very important, right? So that was the story related to the rheumatoid arthritis, right? The last topic for the discussion, right? We have a middle-aged woman with history of back pain came to the OPD. On examination, she was positive for the Schobers test. Her nose and ears were hyperpigmented. What do you think is the diagnosis? Right, only one student answered correctly. Shravani Kodali and VPR now. Right, so answer is not ankylosing spondylitis. So the answer is the ochronosis. The answer is ochronosis. Right, why the answer is ochronosis? Why? Because nose and ears were hyperpigmented. That is not the feature of ankylosing spondylitis. That is a feature of the ochronosis. Okay, so ochronosis is what? It is bluish black discoloration. What is the discoloration that you will have here? The discoloration that you will have is bluish black discoloration of certain tissues. What all the tissues will undergo hyperpigmentation in ochronosis? That will be ear, and that will be even the eye, that is ocular tissue. Even the ocular tissue. That is the hallmark of ochronosis. Hyperpigmentation is a hallmark of the ochronosis. And in ochronosis, you also have the involvement of spine, similar to that of ankylosing spondylitis. Okay. And hypoparathyroidism, that is easily ruled out, right? And you take the fluorosis. Fluorosis, you don't have the hyperpigmentation. And dental symptoms should be there in fluorosis. And the patient is not having the dental symptoms, right? And you take the Schober's test. You take the Schober's test. Schober's test, like it is positive whenever there is spine involvement. Mucronosis also there is spine involvement. And ankylosing spondylitis also there is spine involvement. So thereby the Schober's test will be positive in both, right? So in case of the ankylosing spondylitis, the two important structures which are affected is spine, where there will be fusion of the vertebra. And the next important is the involvement of the sacroiliac joint. Okay. And what will be the characteristic features in these patients with ankylosing spondylitis? The patient will be complaining of low back pain. And this low back pain, right? Yeah, it is not only, yes, the another important is female. Yeah. So this ankylosing spondylitis, this is more common in males rather than females. So there are many tricky points in this question. Okay, right. Okay. Now, yes, in these patients with ankylosing spondylitis, they will have low back pain that will be there for almost 3 months. And there will be nocturnal worsening of the pain. Nocturnal worsening of the pain. And in patients with ankylosing spondylitis, it is not only articular manifestations. There are also the extra-articular manifestations. And what will be the most common extra-articular manifestation? That will be the uveitis. Uveitis is the most common, and that too, what type of uveitis? Anterior uveitis is observed in case of the ankylosing spondylitis. And cardiac involvement will be in the form of the aortic regurgitation, ischemic heart disease, and as well as third-degree AV block. Lung involvement will be in the form of upper lobe fibrosis of the lung. Skin involvement, that is psoriasis. Spine involvement in the form of cauda equina syndrome. Okay. So that is observed. Yeah. Even what will happen to the chest wall expansion? The chest wall expansion is reduced. Right? Chest wall expansion is reduced in case of the ankylosing spondylitis. Okay. And what is this particular test? This particular test is nothing but the Schober's test. Okay. So the distance between upper point and lower point, actually it should increase by more than 5 centimeters whenever the individual bend. But if the increase in the distance between upper point and lower point, whenever the individual bends, if it is less than 5 centimeters, that tells that there is involvement of the spine. And what is the characteristic X-ray here? That is the bamboo spine is what you will observe. And the another important sign is dagger sign. What is this particular dagger sign? Dagger sign is due to the ossification of the supraspinous and as well as the interspinous ligament. So due to ossification of the supraspinous and interspinous ligament in ankylosing spondylitis, they'll have dagger sign. Okay. And this is the normal sacroiliac joint. This is the normal sacroiliac joint. But what will happen to the sacroiliac joint in ankylosing spondylitis? You can observe that. So this is how the sacroiliac joint in case of the ankylosing spondylitis. Right? Yeah. Yes, Akshay, what is the most common cause of death? The most common cause of death in patients with ankylosing spondylitis is fracture of rigid osteoporotic spine. Fracture of rigid osteoporotic spine. That is a common cause of death in patients with the ankylosing spondylitis. Okay, right. Then coming to the treatment. What is the treatment of choice in seronegative spondyloarthropathies? What are all the actually examples of seronegative spondyloarthropathies? Examples of seronegative spondyloarthropathies are pair. That includes the psoriatic arthritis, then ankylosing spondylitis, inflammatory bowel disease, then Reiter's or reactive arthritis. Reiter's or reactive arthritis. Okay. Yeah. So the treatment of choice will be the indomethacin. NSAIDs should be given. Okay. And if the patient is not responding to your NSAIDs, then in case of NSAID resistant cases, we need to give the TNF inhibitors. We need to give TNF inhibitors. And we have some new molecules which have come up, which are highly effective in the treatment of ankylosing spondylitis. That is interleukin 17A inhibitors. These are the new molecules in the treatment of ankylosing spondylitis. What are these interleukin 17A inhibitors? The examples, they include secukinumab, right? And another important example is Ixekizumab, right? So these are the examples of interleukin 17A inhibitors. Basically, what they will do, they inhibit the pro-inflammatory cytokine interleukin 17. They inhibit this pro-inflammatory cytokine interleukin 17, and thereby they are highly effective in the treatment of the ankylosing spondylitis. And is there any role of corticosteroids in case of ankylosing spondylitis? No. They have very minimal impact on arthritis. Okay, so this corticosteroids will further worsen the osteopenia. So that is the reason why we don't give corticosteroids in case of ankylosing spondylitis. Okay, right. The last topic for the discussion. Yeah, most common organism causing the retards or reactive arthritis. Yes, right. That is the chlamydia. And that too, it's a chlamydia trachomatis. Chlamydia trachomatis. The other organisms that can be causing the retards or reactive arthritis is, it includes Shigella, right? Shigella. Then the Shigella transmission is by gastrointestinal infection, contamination. Whereas chlamydia trachomatis infection is by the sexually transmitted disease, right? So what is a triad in case of the retards? The triad will be asymmetrical arthritis, mainly the joints of the lower limbs are commonly affected. There will be urethritis, where the patient will be coming with burning micturition, and then the conjunctivitis. So arthritis, urethritis, and conjunctivitis, right? And you have this characteristic skin manifestation, which is called keratoderma blennorrhagica. Characteristic skin manifestation is keratoderma blennorrhagica, right? And what is the HLA in case of retards? That is HLA B27. And how will you diagnose your retards? You need to do stool culture and as well as urine culture, where you will be able to pick up the organism. What is the drug that you will be giving? For arthritis, you need to give NSAIDs. Okay. And for this infection, you need to give the antibiotics like doxycycline should be given. Doxycycline cannot be. Yeah, Sunil Acharya, what they will describe is can't see, can't pee, and can't climb, right? So that is about the story related to the ankylosing spondylitis. So with this, we are done with the topics of the connective tissue disorders, right? So, kaise laga hai? How was the session? So we are done with all these topics, right? So 2 topics we have finished today. One is cardiology and as well as connective tissue disorders. I will take one more session, right? I will take one more session. So in that session, I will discuss neurology, I will discuss pulmonology, I will discuss nephrology, I will discuss gastroenterology, and I'll also discuss hepatobiliary system as well. Okay, right. So with this, we'll wind up this session, right? So, yeah. Right. So thank you very much and see you again in the next session, right? Next session, I will just see the date because the dates are completely occupied on this channel. So, yeah, Mera Telegram group is this. This is my Telegram channel. That is Medicine Made Easy by Dr. Rajesh Gubba. This is my Telegram channel. Okay. So I'll be sending the PDFs with annotation on my Telegram channel. Okay. Right. Sure. So see you again in the next session. Thank you very much and good night.